Good morning and welcome to ASPC's Imaging Masterclass for Prevention. My name's Allison Bailey. I'm a cardiologist in Chattanooga, Tennessee, and I'm joined this morning by Leandro Slipchik. I'm going to let him introduce himself.
Hi, everyone. So happy to be here with you. I'm Leandro Slipchuk. I work at Montefiore, where I'm a cardiologist. I'm the Director of Advanced Cardiac Imaging and the Cardiovascular Atherosclerosis and Lipid Disorder Center. Good morning to everyone.
Well, so first of all, we're really excited everyone is joining us on a Saturday morning when you can be doing lots of other things with your time. We are doing this meeting as part of the American Society that we're incredibly interested in is how do we prevent disease in using the latest and greatest tools that we have available. So this imaging masterclass idea came around a few years ago as we recognize not only is this imaging experts that are in the field of prevention, it's all sorts of us. And so we decided we needed to talk about what exists and how do we use that in our practice every day when we take care of patients. I want to just talk a few minutes about some of the other things the American Society of Preventive Cardiology offers. If you haven't yet, please check out the American Journal of Preventive Cardiology. This is the official journal of our organization. There's discount submission prices for ASPC members, and we would love to see lots of people present their data here. It's open access, and we have an impact factor of 4.4. Additionally, ASPC membership is free for anyone still in training. It's also a really great price for people who are out of training. We have $150 for physician members and $75 for health professionals. But please share this information with anyone that you know that may be interested. And then finally, we have an annual Congress every year. And this year it's in Boston. It's August the 1st through the 3rd. And we would love to see as many of you who can attend as possible. I'm going to hand it over to my co-chair now and kind of give us a little bit of an update on why we're doing this.
Thank you so much, Alison. So it's again a real pleasure to be here amongst friends and world experts in the field. So thank you to ASPC and Stacy for putting all this together. So why are we doing this? So right now, when we look at ASCVD primary prevention guidelines, these are currently driven by risk factor calculators, as you can see there from the primary prevention cholesterol guidance. But we know that these risk calculators are heavily influenced by age, leaving many times the young unprotected. We know that they do not capture all risk factors such as family history, HIV, high lipoprotein A, or immune-mediated inflammatory diseases. We know also that these risk factors can fluctuate over time, and the risk calculators only offer a snapshot without taking into account the history, such as cholesterol years that has been coined by Michael Shapiro. We know that genetics are ignored. We have these risk enhancers, but in general, they're ignored. And imaging plays a central role in the precision treatment in preventive cardiology. So we put together this meeting where we are going to be talking first about cardiac CT for subclinical CAD with anatomic imaging. Then we will be talking about beyond CAC and CCTA and stenosis. And then we'll be talking about imaging for prevention in specific populations that can be very challenging when we're managing patients. So it's a real honor to have now to introduce the first session. We'll have Fatima Rodriguez that will be talking about coronary artery calcium. Then we'll have Maros Forensic talking about CT coronary angiography, if there's any role in asymptomatic patients. Mike Plaha will be talking about de-risking through imaging, when and how. And David Maron will be talking about stages of CAD with CCTA. So it's a real honor to introduce now Fatima Rodriguez. She's an associate professor of medicine, section chief of preventive cardiology, the associate director of Stanford Center for Digital Health, and recently named vice chair of clinical research at Stanford. Thank you very much, Fatima, for being with us.
Thank you so much, Dr. Slipchuk, Dr. Bailey, for inviting me to be in today's presentation. So I am delighted to be here and delighted to talk about our first session, which is a simple tool that we can use to better refine cardiovascular risk in our patients. And it's really around the role of coronary artery calcium testing. So I want to just have a practical discussion as a preventive cardiologist, when do I order it and how to use it based on the latest evidence. So today we'll talk a little bit about cardiovascular risk assessment, What do the guidelines say around coronary artery calcium testing? And how does coronary artery calcium scores impact our treatment decisions? So let me just start off with a patient case. This is a patient that I saw in clinic, and she came to see me because of an extensive family history of heart disease. And she was told by her primary care doctor that her labs and everything looked fine. Everything was sort of in the green range. Her known past medical history was only for preeclampsia many years previously during her last pregnancy. And after that, she had been told that taking a baby aspirin was reasonable, so she had been on a baby aspirin. That's her cholesterol panel there, and although she does not carry a diagnosis of a high blood pressure, her blood pressure during the clinic visit was 135/80. So as we just heard, the way we traditionally assess cardiovascular risk is really based on risk equations, and they're quite imprecise. And real questions are around, do we start a patient like this on a statin, and if so, what intensity? So I just wanted to start by saying that although we divide prevention into these categories, into primary, secondary prevention, it's really a continuum. And particularly when we talk about imaging in asymptomatic individuals, is that primary, is that secondary prevention? And we've sort of coined that prevention 1.5, which is the subclinical atherosclerosis, but that is already the presence of the disease. And we know that atherosclerosis is an insidious process, and it starts early in the life course. And until now, we haven't really spent a lot of time trying to identify the disease process earlier. And of course, starting early, and that's really primordial prevention. You prevent risk factors development. That's really communities working with the public health system. But again, it's much, much better to move upstream and not like what many of us do, which is high risk secondary prevention after patients have had events. So we just heard from Dr. Slipshocks about the pooled cohort equations. So this is really what we tend to use to assess cardiovascular risk. And if we plug in the numbers for a patient like Maria, and again, these are based on traditional risk factors, cholesterol, blood pressure, diabetes, and presence of treatment for these disorders, we can see that they can be imprecise and again, very much driven by things like age and sex. So when we plug in Maria's numbers, her total predicted 10-year risk is 7.8%. And according to the guidelines, this is really intermediate risk. I did want to highlight that there's a new kind of kid on the block for risk prediction, and this is the PREVENT equation that was created by the American Heart Association, American College of Cardiology. And this is meant to be more precise and to not think only about atherosclerotic disease, which has been the focus for many of us, but really to think about the interplay between cardiovascular, kidney, and metabolic conditions. Notably, this risk equation removes race from risk prediction estimates and instead allows the option to replace it with place. So understanding the importance of social determinants of health. It contains zip code, hemoglobin A1C, BMI, and importantly, kidney function. But again, if we plug this in for Maria, the percentage is around also intermediate risk. So what do we do with intermediate risk individuals? So something that we rely on very heavily in our preventive cardiology practice is a gated cardiac CT for coronary calcium scans. And these, as you all know, are very precise scans that require low dose radiations that are gated to the timing of the heart beating to try to very accurately quantify the amount of calcified. And I'll kind of emphasize calcified because you'll hear talks later today about ways to determine other types of plaque. And there's been robust epidemiological data that really shows that as the amount of calcified plaque increases in the coronary arteries, as shown here by this data from the MESA study, your risk of having a cardiovascular event goes up, and again, in a very stepwise pattern. And again, this has also been shown to be true across diverse populations, again, from data from the MESA cohort here. There have been many studies, this is one of them, that just shows that really CAC is superior to several other risk factors in predicting cardiovascular risk, as shown here by AUC for its performance for this test. In addition to the Framingham risk score, this is really additive information and really beyond anything else that we can do in cardiovascular medicine. This is data from my good friend, Dr. Karim Nasir, showing that the other value of having a CAC scan is really to de-risk patients. So some patients, despite elevated cardiovascular risk, may actually have a calcium score of 0. And again, good data that can help inform shared decision-making around need for statin therapy. And the most important reason that we can get a calcium scan is because in patients that have calcium, using statins can reduce the risk of MACE. So I tell this to my patients, the presence of calcium is a very actionable thing that we can do, which is to use statins. So what do the guidelines say about CAC? So again, we just saw the slide previously around the 2019 ACC/HA guideline on primary prevention. And again, we see that this is around risk prediction and the risk equations that have some limitations, again, as we heard, particularly in younger individuals or individuals who have not had enough time yet to build the risk factors for cardiovascular disease. These guidelines do highlight the presence of risk-enhancing factors that may make you move to a certain direction. And again, they highlight that in individuals that are intermediate risk, and I would also say probably those that have significant amount of additional risk factors, consideration of CAC testing is helpful to guide treatment decisions. And really, CAC score of any level when you're young should motivate decisions around adding statins. And again, just zooming in a little bit, we can see a 2A level recommendation, again, all based on very robust epidemiological but not randomized data, that in intermediate risk adults or selected borderline risk patients, CAC score can be helpful. And again, if the CAC score is between 1 to 99, it is reasonable to initiate statin therapy. And if a CAC score based on age, and if CAC score is 100 or higher, or the 75th percentile, it is reasonable to initiate statins. This is just more updated guidance. Again, this is from the 2022 ACC Expert Consensus Decision Pathway. So in adults with CAC, this gives you a little bit more granular details on what to do based on the CAC number. And again, very helpful to guide decisions, and especially when there may be patient hesitancy. We have found in clinical practice, and I'm sure many of you have, that once you show a patient the presence of cardiovascular disease, of atherosclerosis in imaging, it's really a very powerful motivator. There's also been a recent guidance around cardio-kidney metabolic syndrome, and this is a presidential statement that was developed by and led by my colleague Chadi Namdoulle from Johns Hopkins, and again showing that the presence of calcium is really subclinical disease, and that already denotes you're in a stage 3 CKM, which can make you eligible for additional therapies to guide cardiovascular risk reduction. So how about incidental CAC? This is something that we spend a lot of times doing in our research world. So using information that is already available. So of course, this can allow for early intervention, can maximize existing resources without additional cost, radiation, or inconvenience to the patient. And again, there's several AI tools out there that can help detect and do this more efficiently and accurately in non-gated chest CT. And this really broadens access and enhances preventive care for diverse populations and other populations that may not seek preventive care. And remember that most gated scans do require a small but could be significant out-of-pocket cost for our patients. What are the costs? The cost is that the precise estimation of CAC may be limited. Sometimes these AI algorithms give you more ranges, which again are basically all we need for understanding treatment decisions. There could be competing risks for indications for CT scans. Why are these patients getting CT scans, right? We want to make sure we're notifying the right patients who can benefit from risk reduction. Sometimes this results in downstream unnecessary testing. So if you have a non-gated scan or incidental calcium, a lot of these patients end up getting additional testing to confirm the observation. And who's responsible for the finding? Is it the ordering physician? Is it the primary care doctor? Is it the radiologist? So a lot of this still needs to be worked out, but I think this is really an exciting area of using information that is already available to help our patients. And just to highlight this is just a simple summary of some work that we've done here at Stanford, led by my colleagues, Dr. Alex Sando and David Marin. CAC is a powerful motivator for shared decision-making. We identified patients within the Stanford healthcare system who had non-gated chest CTs and notified them of the presence of incidental coronary calcium as identified through an AI algorithm, showed them a personalized picture as the one showed here, depicting coronary artery calcium. And then in those that we did not notify, around 7% started statins at 6 months, but those we notified, 51.2% started statins at 6 months, which is a remarkable effect size just for notification of incidental calcium. And of course, when you notify patients around the presence of a strong cardiovascular risk marker like CAC, it also changes behavior around other cardiovascular risk factors. We have recently published data around the persistence of statin therapy around 18 months after notification. And again, the hypothesis that visualizing atherosclerosis is a powerful motivator. So finally, how do we use the exact calcium score to help us in treatment decisions? And again, a lot of very robust epidemiological data that patients with CAC scores over 300 have a similar MACE risk to those with established ASCVD. And this is shown here, again, data for our colleague Matt Budoff, that really once you get to a score of 300, your risk is very equivalent to those of established prior ASCVD. And again, in those with a CAC score of 0, the risk is very low and a graded relationship with other CACs numbers. I call this excellent paper that was published by my colleague, Dr. David Marin, who you'll hear from later, around how to look at coronary artery calcium really in stages to personalize preventive interventions. And this is certainly what we do in our practice. Very important, when a calcium score is 0, that does not mean that you have 0 risk of heart disease ever, especially we just heard the term cholesterol years or cholesterol park years. This is particularly true for our young patients who may not have had time to develop plaque, especially calcified plaque yet. So in these patients, we certainly emphasize the American Heart Association's Life's Essential 8 about optimal risk factor control, focusing on lifestyle interventions. And consider repeating a calcium score, again, based on their level of risk, particularly in diabetics. Sometimes we repeat the calcium score in around 3 years, but for most patients, 5 years is usually the time that we would consider repeating this calcium scan. If the calcium score is between 1 to 99, again, we focus really on lowering LDL here. This is mild atherosclerosis, mild plaque levels. LDLs under 100 are usually the target here. Once you have a calcium score higher than that, it's really important to start considering lowering LDL levels further. I mean, this is really around less than 70 and considering addition of aspirin therapy as well. We talked about the calcium scores above 300 really start getting to the level of ASCVD risk. And here we drive LDL under 55 and consider the use of adjunct non-statin therapies. And again, when you have calcium scores above 1,000, that's a really high risk populations. LDL as low as possible, even though we have under 55, and considering other emerging therapies to reduce cardiovascular risk. So back to our patient. So she had a calcium score, and you can see here significant calcium in her coronary arteries. So her calcium score was over 300. We started her on intense lipid lowering therapy, as shown here. She rapidly achieved a goal LDL, and she was already on low dose aspirin. We identified a whole bunch of other cardiovascular risk factors that had been undiagnosed, including pre-diabetes and hypertension. She's doing very well and adherent to therapy many years later. So in conclusion, CAC testing enhances cardiovascular risk assessment beyond traditional risk equations, and particularly is a strong motivator for shared decision-making. CAC scores over 300, this is really a risk equivalent to establish ASCVD, and we recommend treating those patients at that level. And personalized treatment decision based on a CAC score can optimize preventive care. Thank you so much for your attention, and I'll turn it over to Dr. Bailey.
Dr. Rodriguez, thank you so much. That was really an excellent intro into our session today, talking all about how we use imaging in prevention and really starting at the beginning with CAC. So I'm very excited to introduce our next speaker, which is Dr. Maros Brindnik, who's a professor of medicine and radiology and section head of cardiovascular imaging at the Knight Cardiovascular Institute at Oregon Health and Science University. He's also the president of the Society of Cardiovascular Computed Tomography currently. And he's going to be talking to us today about CT coronary angiography and is there a role in asymptomatic patients? Thank you.
Thank you, Allison, and thank you, ASPC, for the introduction and invitation to talk today. These are my disclosures. So I will talk about coronary CTA and potential role in asymptomatic patients. And I'll start with how the recent guidelines for chest pain actually changed the definition of known coronary disease. And we now define any presence of plaque, including calcified and non-calcified plaque, as the presence of coronary artery disease. And it was indeed the intent of guideline writers to make sure that all the patients that have coronary atherosclerosis detected are treated with preventive treatments. This is on the picture that traditionally, again, in cardiology, we focus most on that right-hand side when you had obstructive disease detected by invasive cath or by stress testing. And now we talk about all these patients that on the left-hand side have just small amount of plaque, potentially both calcified and non-calcified. As previous speaker Fatima said, calcium scoring really has been used in preventive cardiology in asymptomatic patients. Very simple, easy to reproduce, has strong predictive data, and will not repeat it really, but from large epidemiologic study, from MESA, Framingham Heart Study, showing that there's increased risk of events. There's also the other side of the spectrum, where if you have calcium score of 0, and these are data from the Leslie Shaw and the Calcium Consortium on thousands of patients for 15 years. If you basically don't have calcium, your total mortality, the hardest event you can imagine, at 15 years is 3%, irrespective of your basically baseline risk of events, really de-risking very efficiently patients in a preventive realm. On top of it, in preventive cardiology, people are used to this test in general practice as well. And it has a very simple stratification of risk. You have score of 0, very low risk, 1 to 100, like a single risk factor, 2-fold increase, moderate calcification, 100 to 300, 4-fold risk, like diabetes. And then you have basically equivalent of CAD as we talk about it, when you have calcium score more than 300 or 400. And we know that there is effective treatment or in those who have calcium that's increased. And the bottom line, over 100 or over 300, you have better outcomes with statin treatment. And it's now embedded in both the AHA-ACC as well as ASPC, or National Lipid Association guidelines. So we know what to do in clinical practice. However, we have a large randomized trial, DANCAVAS, that when calcium with other preventive measures and other tests was employed, really as a primary outcome, overall cumulative incidence of death didn't show significant difference between those who were randomized to calcium scoring and not. Actually, it was invited for screening, but that was the intention of screening. There was a trend on the right upper hand. You can see that in those that were younger, less than 70%, there was actually reduction of primary endpoint, and this will be important in our next discussion. So where does the coronary CTA stand here? So first of all, I would like to explain to you what the coronary CTA sees. And I think it's very important. We'll have a little bit more talks about how to quantify plaque and so forth, but these are the fundamental things to understand. So our sensitivity and specificity to detect plaque as compared to intravascular ultrasound, that intravascular technique, is very good. We are over 90% sensitivity and specificity to detect plaques as compared intravascular ultrasound. Now, we do need to understand what plaques we see, because the atherosclerosis occurs or develops over that lifetime, starting with fatty streaks, going to sort of complex plaques that cause events. Now, when we do coronary CTA, we see plaques that are larger than 1 millimeter in thickness, or at least 750 microns. So plaques that are relatively large. These are not fatty streak or small plaques. And we see them mostly in the proximal coronary arteries. On the right-hand side, you see that they are in the more sort of proximal vessels in actually, this is not, the slide didn't reproduce well, but that's what it was supposed to show. We do know that we are fairly reproducible. You have a high inter-observer variability when we sort of image the plaques over, again, 90% kappa for detecting plaques. Back when I started doing this work, now it's this more than 20 years ago, it was really difficult to quantify how much calcified and non-calcified plaque on CTA there is. These are sort of one of the first softwares approximately 20 years ago when we used in ROMICAT 1 trial, and it took 30 to 45 minutes to segment coronary plaque in one patient. Now, this has changed. Due to AI and deep learning analysis algorithms, we are now able to detect and quantify plaque very quickly. These are data from Damini Day and Andrew Lynn's group from Cedars-Sinai, showing that deep learning analysis can segment and detect, quantify plaque in a short period of time, in a few seconds as compared to 25 minutes. And these results are fairly reproducible in between the both readers and between CTA in intravascular ultrasound. So now in practice, we actually have multiple commercially available softwares or applications that you can work with and get the total plaque quantifications very quickly and fairly reproducibly. These data have been now reproduced for all of those 3 vendors that are on the previous slide. We can see that they reproduce their data against intravascular ultrasound with fairly good correlation between CT and intravascular ultrasound. They also have shown that these types of algorithms, these are data again from Damini Day, actually predict future cardiovascular events. This is from Cedars-Sinai group showing that if you have more than a median amount of plaque, around 239 millimeter cube of plaque, and it's important to remember this number, 239 or over 200 millimeter cube of plaque. If you have more than median amount of plaque, you have a significantly increased risk of future myocardial infarction. So important predictor of future cardiovascular events. There is additional information to total plaque volume when you actually do CTA, because you can actually quantify types of plaques that you have. And Scott Hardata and Michelle Williams had shown that actually the low attenuation plaque that correlates in intravascular ultrasound on histology better with plaque that is cholesterol rich and more risky or high risk or vulnerable plaque. That type of plaque, more you have that, higher the risk of future cardiovascular events you have, even if you control for other measures of plaque as well as amount of calcified plaque in this study from Michelle. The data were extended now to various population. Ischemia trial, as you all know very well, studied patients with quite advanced disease, had ischemia on testing, a lot of obstructive coronary disease, a large amount of plaque, actually, on average in this population. And in this population, even in this sort of quite diseased population, the total amount of plaque and decrease in lumen, so sort of measuring also stenosis, both were predictive of future cardiovascular events. As you can see again here in this group, there are the categories of the sort of disease amount, and they are in these 0 to 250, 250 to 750, and more than 50 millimeter cubed, in pretty large amounts of plaque. There is now very hot off press. Actually, I just added this slide yesterday that just came in press from Dadal and a group from the Netherlands, showing that AI plaque analysis using Clearly software actually for plaque atheroma volume was incremental to cardiovascular risk factor calcium score in assessment of risk of future myocardial infarction. This was 2,400 symptomatic patients. Still, as you can see, we are talking about symptomatic patients and symptomatic data, but one of the first studies that show incremental value of coronary calcium. We just presented data at the ACC meeting on Monday. Actually, these are data from the PROMISE trial. PROMISE trial, symptomatic population, relatively lower risk, less of obstructive coronary disease. And as you can see, much lower amount of plaque, 39 millimeter cube was actually median amount of plaque. Also, this was used with sort of manual segmentation, which will be another important point, or plaque burden of 27%, predicted future cardiovascular events, adjusting for cardiovascular risk factors, statin use, presence of stenosis, and also the presence of coronary artery calcium score and high-risk plaque. So showing that in addition to all these variable measures of plaque burden, or coronary artery disease burden, as well as obstructive coronary disease in PROMISE trial actually did present was predictive of future of cardiovascular events. Now, very soon we will have data from preventive populations on the predictive value of quantitative plaque. Here are two large studies, Miami Heart study led by Kuram and Scapis study from Scandinavia on preventive patients. Now, we do have at this point data on on distributions of plaques and that we understand a little bit better what the quantitative plaque assessment can do. We do have data from also Copenhagen General Population Study, almost 10,000 patients, approximately half of them have atherosclerosis, and we're starting to have the predictive data in this preventive population. As you can see in the graphs, the amount of disease, coronary disease, both obstructive as semi-quantitative, the amount of plaque, actually by number of segments, are providing a gradual increase of risk of future cardiovascular events in this preventive population. Now, this study did not have additional additive value to coronary calcium, so we cannot directly compare it, but we do have data in this preventive group as well. Now, Miami Heart Study has a publication that is now in press and was published or presented at SCCT meeting last year. And in Miami Heart Study, they actually did perform a quantitative assessment using a Clearly platform. And now they have nomogram data for asymptomatic, relatively young and a relatively diverse population. And as you can see, the amounts of plaques, again, are much smaller than some of these trials like ischemia, Scott Hart, talking about more in the term of 20, 30, 50, 70 millimeter cube of plaque, of total plaque volume. Now, what is very interesting in this population, it also gives us a glimpse how the plaque composition changes as you get older. And as you can see here, as you get older, the amount of calcified plaque goes on the right-hand side up, and then amount of non-calcified plaque in the terms of proportion goes down. You also see that these quantitative plaque assessments on the left-hand side are capturing a lot of patients with plaque, and we will have to learn how to deal with the fact that more than 80% of people actually around the age of 53, median age, actually have plaque when you do this quantitative plaque analysis. Now, what is really the strength of quantitative plaque analysis is that we understand more about plaque compositions. We know that dense calcified plaque actually associated with lower risk of future acute coronary syndrome. It's the plaque that is non-calcified on the left-hand side, has low CT attenuation that predicts where future events will be. We also know that the rapid progression of plaques over the follow-up period that you can see on CTA is predicted by measures of plaque burden, non-calcified plaque, amount of total plaque volume are the strongest predictor in blue in the right upper hand corner. We also know that both the baseline amount of plaque and rapid progression, those are the red lines on this survival curve, are associated with higher risk of future cardiovascular events. So it's not only the baseline amount of plaque when you do the CTA, but also the plaque progression on CTA that predicts future cardiovascular events. We also understand that statins specifically target non-calcified plaque. In the left upper corner, you have see decrease of non-calcified plaque volumes. And the bottom line, you can see increase in densely calcified plaque as you undergo statin treatment. And finally, we have even these small data for similar changes when you do lifestyle modification, very similar. The plaque composition changes when you do successful implementation of lifestyle therapies. Now, very intriguing findings are this from the CORE trial, very hot off press, where you use calcium to stratify whether or not to treat, but to see how successful your treatment is. So you're decreasing total plaque volume, non-calcified plaque volume, or fibrofatty non-calcified plaque volume. It's actually CTA that can capture these changes, not calcium scoring. There are challenges. There are really high variabilities, and this was highlighted in this consensus stay document on the quantification of CTA from SCCT, just published last winter. There's a lot of variability in the softwares. There is, as I already mentioned, like what really the normal values for normal populations are, we don't know. You can see this population vary from 0 to 750, actually average of 450 in Simmons' study, much lower in the right-hand side from the SCAPIS or even from from Miami Heart, and right-hand from PROMISE. So we need to figure out this before implementing. And the new scanners will affect what we see. The photon counting scanners are coming. they actually modify what we see, how much calcified, non-calcified plaque there is. They are better in detecting and quantifying, defining the plaque, but they have different quantification. So we'll have 3 large randomized trials that are ongoing that will have quantitative data, DANE-HART, SCOT-HART, and TRANSFORM in preventive population. Hopefully in the next 2-3 years will tell us what the role of CTA is and will really inform future guidelines. So my really view here is that in the future, we will something like this came from the ACC group, that we will have basically guidance based on CTA, follow-up CTAs, how to treat the patient and how to modify and intensify our treatments to achieve really the ultimate goal. And to monitor this, we will need CTA. Plaque regression, decrease in the amount of non-calcified plaque, as you can see in this patient that was on PCSK9 inhibitor, young patients with a lot of non-calcified plaque, low density plaque. CTA can detect the changes that happened with this patient. So in summary, what I see, we have borderline probably increase in predictive value. I think it may be employed in specific population, younger patients, women, patients with strong family history that potentially can detect this non-calcified plaque early, if that's appropriate from the sort of shared decision-making with the patient. We will have the data soon from asymptomatic population from Miami Heart and SCAPIS. We will have soon randomized trials in preventive population and the role of CCTA. If we want to monitor plaque changes over time and monitor coronary atherosclerosis regression, we will need coronary CTA. And with that, I would like to thank you for your attention and thank you once again for the invitation to speak at this webinar.
Thank you very much, Maros. That was an amazing lecture showing what we know about use of CCTA in asymptomatic patients, what the data is now, and where the future will bring on the use of CCTA. So we had a great lecture from Fatima on CAC, showing how we can increase the risk in some patients that may be under-detected with the risk calculators. We talked about CCTA in asymptomatic patients, and now we have a great lecture on how to use imaging when we want to de-risk patients. So for this, we'll have Dr. Michael Blaha, who is an associate professor of cardiology and epidemiology and the director of clinical research for the Johns Hopkins Chickaron Center for the Prevention of Cardiovascular Disease. He will be speaking about de-risking through imaging, when and how. Thank you, Mike, for being here with us.
Thank you, yes, for this invitation to be here. Sorry I'm off video today. I'm going to preserve bandwidth here by staying off video so you can see there my picture. And we're going to talk about de-risking through imaging, when and how. We'll talk about what we mean by de-risking, and I'm going to put this in some clinical context as we go. And we'll talk in the end about 2 specific scenarios where you might want to use imaging to de-risk in your practice. Okay, so I will be talking quite a bit about coronary artery calcium. Now, other imaging techniques like CTA can de-risk patients too, but I think really the initial observations about de-risking really come from the coronary calcium literature. So, of course, the idea being, as you've heard, that with a simple cardiac-gated non-contrast cardiac CT, just 1 millisievert like a mammogram, we can get a quick readout of how much plaque a patient has. And of course, you'll find, as you know, that about a 55-year-old man has about a 55% or 50% chance of having calcium. In other words, also a 50% chance of having no calcium. And we know that even up into older ages, there's still a large fraction of patients who don't exhibit coronary calcium. Now, while we historically have focused our attention on early identification of unheralded plaque, that's important. We're also recognizing the importance of recognizing the unexpected absence of plaque too, and how that could drive clinical decision-making. So just a quick, once again, reminder, as you've heard, why the calcium score works. The calcium score works because it's a direct representation of the total burden of plaque volume. And here's data from MESA, a general asymptomatic population-based study or community-based study that showed the burden of atherosclerosis across the ages. But one of the things you'll notice here in the green is a large fraction of patients in the 45 to 55-year-old age group have no plaque at all, at least no calcified plaque. But even 20% of patients above the age of 75 in MESA had no detectable plaque. And this has been seen repeatedly across studies. And in fact, if you look at CT scans of hunters and gatherers that have done in some interesting studies in Bolivia, 80% of people about the age of 65 or 70 have no plaque. So it's not obligatory that we develop plaque, and there are interesting phenotypes of patients who are resilient and don't develop plaque. So can we use this to de-risk patients? Well, this is data from MESA showing something important, that you have events in direct proportion to your burden of disease. So you'll see here that young patients with high atherosclerosis burden have high event rates, similar to older patients with similar athero burden. But look at the yellow. The yellow, I think, is what's most important for this talk, that patients who have a calcium score of 0 are relatively de-risked. Even at older age, they have relatively low event rates, certainly lower event rates than younger patients with high atherosclerosis burden. These patients have been resilient. They didn't develop calcium. They didn't develop a lot of plaque burden, and they had low event rates. So can that observation drive some of our clinical decision making? That's the question. That's the concept of de-risking. I also wanted to make this point, that the calcium score is not just really a measure of plaque burden, but it's also a measure of biologic age, you could call it, or tissue injury as a result of risk factors. And as a result, the calcium score also predicts non-cardiovascular disease events too. It turns out if your calcium score is 0, you have a reduced risk of developing cancer, CKD, pneumonia, COPD, and even dementia. Once again, it speaks to a resilient phenotype of someone who's really not developing tissue injury or at least atherosclerosis in response to risk factors. So very importantly, you could make graphs that look like this with the calcium score, since it predicts a variety of disease outcomes. What I'm showing here on the x-axis is the age in years. On the y-axis is the calcium score. And in red is when a patient is more likely to die of cardiovascular disease than cancer, which is the second leading cause of death in the United States and around the world. Or blue, when you're more likely to die of cancer than cardiovascular disease. Now, this is important from a clinical point of view, because let's say you're 70 years old and have a calcium score of 0. If you look at that on the graph, you'll see that you're clearly in the zone that you're much more likely to die of non-cardiovascular causes than cardiovascular. And it becomes much more difficult to extend your lifespan, for example, with preventative therapy. But if you look at a 50-year-old with a calcium score of 300, that's well within the red here. You're much more likely to succumb to cardiovascular disease than a non-cardiovascular cause, making our preventive therapies all the more effective or likely to be effective in this population. So this is the idea of using calcium scores not only to de-risk cardiovascular outcomes, but really multiple outcomes and even predict the cause of death. Okay, so if one were to compare a bunch of risk factors that one would perceive to be negative risk markers, the absence of risk, and compare their strength, this was done in MESA by our group many years ago, you'd see that one test stands out by far from the others as being the most reassuring. I'm talking about the absence of a family history, the absence of a C-reactive protein elevation, the absence of a pro-BNP elevation, or, for example, the absence of a calcium score. Turns out that the calcium score of 0 is by far the most powerful negative risk marker amongst these other things. You know, we're constantly encountering in practice patients who don't have a family history, have good diet and exercise, but neither of those are as reassuring as having a calcium score of 0. So we think a calcium score of 0 is the strongest negative risk marker for the development of ASCVD. And this fits with what we call the imaging hypothesis of cardiovascular disease risk detection or prediction, which is due to the superior sensitivity of this test. Imaging tests, like the calcium score, but others too, are excellent for ruling out or downgrading risk estimates. In other words, when there's no plaque, they're very good at predicting low disease risk. So this is, I think, the most important slide in my talk today, is how imaging is fundamentally different than other tests. So I've pointed out a beaker here showing like a lab test. or DNA for like a genetic risk score. Those type of tests are good for detecting, or somewhat good for detecting, unheralded risk. Perhaps finding new patients to treat. Maybe you'd have a blood check and the LPA is high, or you do a genetic risk score and the genetic risk score is high. It's telling you that patient is higher risk than you thought. But these cannot reassure you. Just because you don't have a high LP(a) or have a genetic risk score that looks pretty good, we can't say, well, you're very low risk. You just can't do it with those sorts of tests. In contrast, imaging can find not only those patients that are higher risk than you thought, but they can also find patients that are lower risk than you thought. It's a true risk stratification tool so that we can say a patient with a calcium score of 0, maybe regardless of the LP(a) or the genetic risk score, just doesn't have any major atherosclerosis buildup. So it's very good for finding patients that are low risk. So we've written about this in the past. This is an old study. The conclusion was that the calcium score seems to risk stratify patients that would be eligible for consideration for preventive care and could be used to target subgroups of patients who are expected to derive the most, but also importantly, the least absolute benefit from a therapy, and that focusing treatment on the subset of individuals with measurable atherosclerosis might be the more rational way to approach prevention rather than, for example, treat all or treat everyone the same. And this is the idea of personalized primary prevention. Can we separate the population into patients who are really more likely to benefit from our therapy or patients who are unlikely to have a meaningful extending of their lifespan with, let's say, multiple aggressive therapies? So this is consistent with the guidelines here in the existing 2018 cholesterol guidelines, age set 40 to 75, don't have FH, you do a calcium score. Here it says here when the risk is uncertain, you can do a calcium score, and I'll just go ahead and read what it says here. Class 2A recommendation that in borderline to intermediate risk patients, if the decision about, let's say, treatment is uncertain, it is reasonable to use the calcium score in the decision to withhold, postpone, or initiate therapy. So all of those are written in, it doesn't just say find patients that are higher risk, find patients that are lower risk too. Patients that you might actually change your decision-making to be more conservative. So that's an important point about imaging. And this bears out when we look at studies. On the left is the embedded calcium scores from the St. Francis randomized control trial. We can see on the bottom part of the left panel, if your calcium score was 0, there didn't appear to be much benefit from a statin. And clearly on the absolute scale on the right side of that plot, the absolute risk reduction of the statin was negligible compared to when the calcium score was high. And likewise on the right, the data from the Walter Reed clinical experience. This was propensity matched clinical data showing that when the calcium score was 0, the patients didn't seem to benefit much from a statin, at least over the near term. But when the calcium score was high, there was a large relative and absolute risk reduction with the statin. Once again, patients with a calcium score of 0 didn't really benefit much, at least on the near term, they were de-risked. Okay, so let's go over 2 clinical examples of de-risking to bring this home to something more clinical. And the first example I'm going to bring up is a statin intolerant patient. Certainly this ASPC audience sees plenty of patients with statin intolerance. This was a great paper that you can look at. I did this with Neil Stone and Carl Oringer some time ago in JCL, which is about calcium scoring in patients with statin-associated muscle symptoms and prescribing statins to those actually most likely to benefit. Because we struggle with these patients with statin intolerance, right? Let's say you give someone a statin, you really didn't know their risk, they didn't tolerate the drug, and they say, what do I do next? Do I try a second statin? Do I go on a PCSK9 inhibitor? Or does it turn out I'm really not that high risk? This was an algorithm that was in that document. It's actually hard to see, at least for me here. But the point being is you take that patient with statin intolerance and you consider a calcium score. And there's going to be, depending on your clinical practice environment, there might be a large fraction of patients who in your practice were on a statin and didn't tolerate it, who actually have a calcium score of 0. You might be able to get away with a more conservative approach, diet-based approach, for example, or vice versa. You might identify a patient with a very high calcium score who you absolutely need to do everything you can to get them on aggressive lipid-lowering therapy. But when you don't know the risk, it's very hard to treat these statin-intolerant patients. What do I do next? Here, for example, is the 2022 ACC Expert Consensus Decision Pathway on non-statin use, which explicitly sets LDL goals based on the calcium score. And you can imagine the statin intolerant patient on the left can have anything from a recommendation to defer statin therapy when the calcium score is 0, or on the right when the calcium score is above 1,000, to consideration of a PCSK9 inhibitor on top of a statin to get the LDL less than 70. So a wide range of decision makings in these statin intolerant patients that are very challenging to treat, as you know. So I think a statin intolerance is a great scenario to consider calcium scoring, of course, to find high risk, but also to de-risk certain patients as well. Okay, the next example I wanted to give that's clinically based is about aspirin. We're all confronted with this question about aspirin in daily practice. Do I take an aspirin in primary prevention on the left, the benefit, and on the right, the risk? And on average, it's pretty balanced. So what do I do in this scenario? This was a study that we did looking at calcium scoring in MESA in patients who were less than the age of 70 and didn't have high-risk bleeding features. The important observation here is that the calcium score predicts cardiovascular disease risk, but doesn't predict bleeding risk. So it identifies patients who might have higher cardiovascular risk, but not higher bleeding risk. And when you look at the data here, in the bars is the number needed to treat with aspirin to prevent one event. The red horizontal line is the number needed to harm. And in blue is all comers. And in the colored bars, orange to green, increasing calcium scores. And what you can see in blue is if you don't use the calcium score, you just use all comers, the benefit and the risk are balanced. We can't identify patients with a net benefit from aspirin. And in orange, when the calcium score is 0, you're much more likely to harm patients with aspirin than you are to benefit. And in green, when the calcium score is high, we project a net benefit with aspirin. So you can de-risk patients here too. And say, particularly your patients with calcium scores of 0 who are on aspirin, I take them off aspirin. This was also shown in the Dallas Heart Study. I won't go over this in detail. Again, the tipping point seemed to be around a calcium score of 100, where the ASCVD benefit outstripped the bleeding benefit. And just a quick remark that I've talked about calcium scoring here. This applies to other imaging tools too. There's also interest, particularly around the world, in carotid ultrasound. This is based on a carotid ultrasound-based plaque score, the same analysis. And it's sort of the same thing plays out. If you have a carotid plaque score of 2 or greater, that's when you seem to get a benefit from an aspirin. If you don't have any carotid plaque, you're probably more likely to cause harm for the patient than benefit. This is de-risking. You can de-risk patients that might be otherwise on aspirin. Same thing if you look at intermediate risk patients. This was the conclusion of that study, which once again, the general theme I think of this whole session is that patients with advanced subclinical atherosclerosis may benefit from more aggressive therapy, and patients who lack atherosclerosis probably don't. So I'll summarize by saying that imaging is unique from other risk factors like LDL, Lp(a), or genetic risk score, in that it can actually de-risk a patient. As we know, you can't de-risk a patient just because their LDL is 100, or you can't de-risk a patient whose Lp(a) is normal. They still could have a lot of plaque. And patients at borderline to intermediate risks, especially those with risk-enhancing factors, are excellent patients to consider for imaging tests, but also to de-risk. And many clinical scenarios benefit from de-risking. I use the examples of statin intolerance and aspirin use, but other examples apply too. Patient with severe hypercholesterolemia that does not fit the criteria for FH, low-risk chest pain scenarios, or, for example, if you're doing a nuclear study and you have an equivocal perfusion image, but a calcium score of 0, extremely helpful for de-risking that patient with an equivocal stress test. So with that, I'll say thank you for inviting me to this session. And I guess I'll be around for the question and answer. And it looks like we're on to our next talk. Thank you.
Excellent. Thank you, Mike. What a great talk on de-risking our patients. So for that group of people who are at lower risk, we can sort of talk about the benefits of all the things they're doing right. So it's my honor to welcome our next speaker, Dr. David Moran. He is the professor of medicine at Stanford and the Stanford Prevention Research Center. He's also the current vice president of the American Society of Preventive Cardiology. And he's going to be talking to us about a very important concept today, stages of coronary artery disease and the treatment implications of this. David, welcome.
Thank you, Allison, and thank you and Leandro for the invitation to speak this morning. Yes, I've been asked to talk about the stages of coronary disease, and I just want to give my disclosures that I do have support for doing some research in the TRANSFORM trial from Clearly, and I'm directing a cohort study for HeartFlow. I want to talk about the value of staging, and then talk about two different staging systems, and then hopefully lead us into a great discussion with the previous presenters. So we really haven't incorporated staging into the way we talk about coronary disease, and it is a valuable way to understand the diagnosis, prognosis, and treatment implications for other diseases. And we use staging for lung cancer, for colon cancer, for breast cancer, for stages of liver disease. And as I said, the stage of disease has implications such as how it defines how we should treat breast cancer. So there is a staging system that was developed by radiologists and imaging cardiologists. It's called the CAD-RADS. The second version of this was published in 2022 in the Journal of Cardiovascular Computed Tomography. And I'm going to briefly discuss that staging system and then move on to AI-enabled staging using plaque analysis. So the CAD-RADS system primarily stages on the basis of stenosis severity and plaque burden. And it's very intuitive. The categories go from no atherosclerosis up to 25%, 25 to 50%, 50 to 70%, 70 to 99%, and then total occlusion. And you can see what the scores are there for the category numbers. For plaque, P1, 2, 3, and 4 for mild, moderate, severe, and extensive. And now I just want to show you pictures that go along with this categorizing system. So here's a CAD-RADS 0. There's just no atherosclerosis, no stenosis, no plaque. Here's a score of 1 and P1. 1, remember, is mild. It's less than 25%, and there's a mild amount of plaque burden. Here's a CAD-RADS 2, P2. And so this is up to 50% stenosis and a mild to moderate amount of plaque, compared with a CAD-RADS 4A and P1. You see, it gets a little complicated. Like, are we really going to remember how to categorize these if we see them? But a CAD-RADS 4 goes up to a 99% stenosis, but there's a mild plaque burden seen on the coronary CT angiogram. And here is a CAD-RADS 5 with a moderately severe plaque burden. A CAD-RADS 5 is a total occlusion. So compared with a CAD-RADS system is a staging system based on plaque volume severity. And this form of staging has become possible because of machine learning algorithms that can quantitate the amount of plaque seen on a coronary CT angiogram. And this is a staging system developed by the Clearly company. Their definitions are a stage 0, which is no plaque, stage 1, which is up to 250 cubic millimeters of plaque, or greater than 0, but up to 5% atheroma volume. And then stage 2 is 250 to 750 cubic millimeters, or percent atheroma volume of greater than 5 to up to 15%. And stage 3, which would be greater than 750 cubic millimeters, or greater than 15% atheroma volume. This staging system has been used to predict the event rates in various populations. And it looks like it is more effective than the risk calculators that you've heard about and others have discussed this morning. Compared with coronary calcium, there is a net reclassification improvement using coronary CT angiography staging compared with the coronary artery calcium score. These are data from the ischemia trial, converting cubic millimeters into stages 1, 2, and 3, looking at the event rates, the cumulative incidence of cardiovascular death or MI in the ischemia trial. And you can see that as the stage number increases, so did the risk of having an event. And shown in this graph is a clear relationship between plaque volume and risk of events. HeartFlow has also developed a staging system, which thankfully is very similar to the system developed by Clearly. Here you can see.
Can't do that.
Oh, sorry, series. So the stage 1 is up to 100 cubic millimeters. They call that mild. Moderate is up to 250 cubic millimeters of plaque. And then very similar to the Clearly, or identical to Clearly, is 250 to 750, which is called severe in their staging system, and extensive, greater than 750 cubic millimeters. Now, they have attached to these stages some treatment implications, which you can see on this table. And they have different LDL goals. For mild, it's less than 100 LDL. For moderate, less than 70. For severe, less than 55, and for extensive, less than 50. As with the Clearly and the ischemia report that I showed a couple slides back, this also shows the relationship between stage and the risk of having a major adverse cardiovascular event. On the left is unadjusted and right adjusted data. Lastly, I'm just going to speak for a moment about the Transform trial. We are in the process of randomizing.
Who do you want to message?
Up to 7,500 men and women with metabolic syndrome, prediabetes, and diabetes who are asymptomatic. So as Dr. Rodriguez said, it's not quite primary prevention, it's 1.5. Everyone will undergo coronary CT angiography and will be randomized into care that is risk factor based versus treatment which is based on the severity of their atherosclerotic burden, according to the Clearly staging system. Those randomized to the risk factor based care will be blinded to the results of the coronary CT angiogram. and those in the clearly stage-based care will be treated according to the severity of the plaque, and the outcome will be a composite of major cardiovascular events.
To who?
This last slide that I want to show is the treatment algorithm associated with stage. If there is zero atherosclerosis, the primary prevention guidelines will be followed for the patients that are randomized to the intensive intervention based on staging. Stage 1, the LDL goal is less than 70, achieved through any combination of lipid-lowering therapy. Patients with diabetes will be treated with a GLP-1 receptor agonist and an SGLT2 inhibitor. In stage 2, the LDL goal is less than 50, and antiplatelet therapy with aspirin will be added, the diabetes medications, and then for stage 3, the LDL goal is less than 30. The antiplatelet therapy will be switched to a P2Y12 inhibitor. Predominantly, it would be clopidogrel. And if there's evidence of inflammation based on a high sensitivity CRP, colchicine will be added. And then, of course, there will be strict attention paid to blood pressure control, glucose control, smoking cessation, and encouragement to be physically active and follow a plant-based diet. I think that is my last slide, and I am looking forward to turning off series on this clicker and heading into the discussion session. Thank you.
To who?
I think you all would agree with me. That was a really great first session for our meeting today. I think we went through an incredible amount of information for both primary prevention and sort of what exists now with calcium scoring and guidelines and what the future looks like with the new technologies that we have. Leandra, I'll see if you have any additional comments before we start our questions.
No, that was outstanding. I think this was very important for people that are experts in the field to learn a little bit more, and also for people that don't have experience. So hopefully this will help you to start your program and start using imaging for prevention.
Well, and we'll again welcome any questions any of our participants today have. Just send them over in the chat and we'll be able to address those. We have one that started off that gave us a patient case. Dr. Rodriguez, this was added to you, but maybe we can ask each of our participants what they think. Patient with a CAC of 92, an LDL of 255, clinical history of familial hyperlipidemia. Is low-dose aspirin indicated in this patient?
How old is the patient?
That
It's not provided.
Not provided.
Yeah, I think the decision around aspirin is a little trickier. Obviously, driving that LDL extremely low. I think we would all agree with that because it's, as we mentioned, it's cholesterol pack years, and somebody with FH has just had longer exposure to that risk factor. So I would drive at the very least the LDL under 55. I would consider this. I imagine this patient may be young. If it's a young patient with that degree, even though it's not meeting our 100, 300 cutoff, I would highly consider baby aspirin. I would also check out lipoprotein A. We haven't done so already because those FH and high lipoprotein A can coexist.
Thank you very much. Amazing answer. And I think with Alison, we wanted to get the input from the other speakers from this point. And if you also maybe want to comment, if you would consider Plavix instead of aspirin in some of these patients.
I guess I'll jump in and give my opinion. Yeah, we didn't hear the age of the patient. I'm guessing it's an FH patient that's on the younger side. And you know, we generally use calcium score of 100 as a good cut point, but of course, it's arbitrary. When the calcium score is 92, I think we heard, it's going to be above 100 next year if we checked it. So yeah, I would definitely use an aspirin in this patient, actually, almost no question. Of course, taking a quick bleeding history, it's a slam dunk. There's not a lot of data for P2Y12 inhibitor monotherapy in primary prevention. So as not to kind of leave the evidence base, I would probably just stick with good old low dose, cheap aspirin, and then of course get the LDL down as you heard. But I'm in agreement.
I would just add that if the Lp(a) is found to be high, that's another reason to include aspirin in the treatment regimen.
I would just quickly say, as we talk about the CTA, I think over the next few years, we will learn more about the relationship between non-calcified and calcified plaque. And as we go to these younger populations, we have the patients that for non-calcified plaque are at high percentile, because now we have now percentiles also for non-calcified plaque only. I think the similar that we can apply to coronary artery calcium, that you have absolute amount, but you have also more than 75th percentile. Maybe we'll be able to upgrade risk and increase the intensity of treatments. As Dr. Maron showed in the Transform, we will have that type of data. Yeah, like we will have an absolute amount of plaque data on clopidogrel. We'll have data to additional therapies, because we will have non-calcified plaque assessment in that population as well as total plaque volume, which it includes that non-calcified plaque.
Just a comment on that, because I imagine this patient has known FH, they have potentially been on statins for a while, and we know that somebody's already on statins, that plaque may have calcified. So again, without knowing the age, it's hard to say, but probably a good idea to do aspirin. But also, I don't routinely get coronary calcium scans on somebody already on statins, especially long-term, because of this exact issue around the soft plaque and the calcified plaque.
And I'll just say one more thing about a patient with FH, and I'm paraphrasing Brown and Goldstein. Just drive the LDL as low as you can. The prognosis is related to the cholesterol years, if you will. And these patients have had high LDL cholesterol certainly since birth. So the lower you get it for the longer period of time, the better the prognosis.
Thank you very much. And for those of you interested more in this topic, we'll have towards the end Raul Santos that will be speaking about this specific population. We have the next question by Rob Fern. He says, based on current data, do we start using CCTA for asymptomatic patients with diabetes and risk factors? Maybe Maros, if you want to address that.
So I don't think we have convincing data to show that these patients have better outcomes. I think that we have a large amount of data for coronary calcium, and I think that would be my primary goal. Now, what happens in the clinic when you talk to the patients, you do often have patients that have very strong history, then are in their 40s or early 50s. And if you have a shared decision making and the patients are really interested whether they have at this point non-calcified plaque, that's a reasonable approach. I would not blanket use it for everybody in the population without outcome data. There is the tricky part, and I want to highlight it from that initial, and it was just, it's like as I said, it's impressed from the Miami Heart. Now you have over 80% of patients that have some plaque. I really think that we will have to, from these primary prevention or asymptomatic patients, figure out where is that threshold that the non-calcified plaque really matters in the outcomes. Because there's very little room for de-risking. We saw the risking for calcium score, but you de-risk half, patients or so that have no calcium. If you can de-risk only 10 to 15% of patients, that's going to become inefficient, I think. Yes, those patients that have completely no non-calcified plaque are probably very, very low risk. The patients probably that have small amount of non-calcified plaque will still have fairly low risk. And we have to learn about it from the prospective studies, how to approach these patients. I don't think we have the data. So that will be a problem for somebody who is young, has diabetes, has family history. You now do AI analysis, you find 10, 20 millimeter cube of non-calcified plaque, no calcium. What to do with the patient, I don't think we really have data. And I would be very careful to treat them aggressively. Again, if that's patient's preference and you make really good discussions about pros and cons, about the limitation of detection, as I showed you, you don't see reliably really those small plaques from the initial data that we have done ex vivo in intravascular ultrasound. I would be just very careful to over-medicate the patients.
If I could, I didn't mention something important about the TRANSFORM trial design, and it goes, it plays into what Dr. Ferencik presented in his presentation. So at 2 years after randomization in the TRANSFORM trial, in which Dr. Rodriguez is participating as well, we are repeating a coronary CT angiogram. And we will be looking for progression. And if we see progression, we will be intensifying therapy, which leads me to disclose in my own practice, a lot of patients ask, well, how am I going to know if the treatment's working? When do I repeat a coronary calcium scan? And I explained that serial calcium scans are really not an effective way to monitor for progression or response to therapy. And so in my practice, I am frequently getting serial or a baseline and then a follow-up coronary CT angiogram. So I can find out for myself and for the patient if the treatment is being effective. This is controversial. It's not paid for by insurance. And we'll find out. We'll find out. I don't know. I'm going to turn off this telephone. I don't know how TRANSFORM will turn out, but that will provide us with the evidence to either support or reject that approach to therapy.
Really great. And you guys are sending in good questions, so keep coming. I think a really important one, is there an age cutoff for calcium scoring? What do you do in your practice? And then is there an age cutoff for CCTA given higher calcium burdens with age? Mike, you want to take that one?
Yeah, I guess we could talk about both ends. I'm not sure if they're talking about the lower end or the higher end, but I can maybe talk about both. Okay, so the question comes up, when do I start doing calcium scoring? Of course, that's one interpretation of the question, especially if you're thinking about more of a screening type approach. Then the other end of the question is interesting too, which is actively undergoing trials as well, which is older patients. What does it have a role in de-risking older patients who are at risk for polypharmacy, multiple comorbidities, medication side effects, and so forth? So there is some good data about when people develop calcium. We've published some of this from our group. We have some nomograms about when 25% of a given clinical phenotype will develop some calcium. We think that's a reasonable metric of when the test becomes useful, when it's about a 1 in 4 chance of having some positivity. And this was a paper that in Jack, but off the top of my head, I know that if you have no risk factors, a man about the age of 42 has about a 1 in 4 chance, and a woman about the age of 58 has about a 1 in 4 chance of having calcium despite no risk factors. And then in that paper, it also talks about more common scenarios that you might be thinking about, let's say family history and hyperlipidemia. It actually goes down to about 35 in men when 1 in 4 patients have calcium, and I believe something like 48 in women. Anyway, so of course it's always a calculus based on the age of the patient, but also the risk factor profile. What I will say is, generally speaking, I think it's underappreciated how early you can develop calcium. It's falsely said over and over that calcium is a late finding in atherosclerosis, that atherosclerosis is present decades before calcium is present. It can't be any more false. There's no data to support that at all, including the CTA literature. So we should be mindful that the calcium score can detect early calcium, and you want to detect people when their score is low. If you've done your first calcium score and it's 1,000, you've missed by 25 years your window for prevention. So I think using calcium scoring selectively younger patients makes sense, and you can look at some of the data. It can be data driven. I think when a 1 in 4 chance the calcium score is positive, I think it's reasonable, and that's where I'm applying it in my practice. So I will test younger patients, younger than 40, selectively, usually men, with multiple risk factors, risk enhancing factors more commonly. So there's that. But I also say that the CAC preventable trial is underway, where patients above the age of 70 are being randomized to atorva versus placebo, and they have half of them will have a blinded calcium score. So we'll also be able to see if there's patients who reach the age of 75 and are apparently healthy who can be de-risked. Of the baseline data look like right now, at least 1 in 5 of those patients have a calcium score of 0. So we'll see. I think there could be a wide range of ages where you use the calcium score, but we have to remember that we use it differently at different ages, right? At young ages, we're not sort of looking to de-risk. We're trying to find that unheralded high risk and treat. At older ages, it shifts a little bit towards de-risking sometimes. So I think it's a nuanced question, but it's a good one, and it can be data driven. We have lots of data on this now.
Thank you very much, Mike. If anyone's interested in reading more about it, I put his publications on the topic on the chat, so you can look at it a little bit better. We'll move to the next question, just in the sense of time. And I'll link 2 questions on this. Someone asked, what's the CAC cutoff to perform CCTA, if we should stop at any point? And the other question that is related somehow to that is the value of photon counting CT. Should we be breaking the bank and buying one? Whoever wants to take it.
So I'll probably.
Oh, you go ahead. Yeah, go ahead.
I'll start. I think it really varies on your practice and your scanner and your quality. I would say I don't apply any calcium threshold with the modern scanners. It doesn't have to be a photon counting scanner. With the modern scanners, good quality protocol, low heart rate, good injection of contrast and nitroglycerin, you can get diagnostic coronary CTA with calcium score in thousands, actually. So what I do when I look at the images is I look at the quality of calcium score. So when the technologists call us, and usually I review the calcium score, and if it's low image noise scan, I see good quality, there's no wall motion, I know the patient has good IV, I would definitely proceed with coronary calcium. So I would not apply a threshold. Now, in terms of photon counting, I don't have a personal experience. I know from the literature and from colleagues that use this, it really improves further quality of our scans. And if you have the means to get one, sure, get one. I would say that at this point, I don't think it's necessity. Again, when you have a good scanner, a wide coverage, good temporal resolution, you can get diagnostic scanning and majority of scanning without photon counting scanner at this point.
Yeah, and I'll give you the perspective of a non-imaging, a preventive cardiologist, so clinically what we do. And again, we don't tend to get CCTAs for primary prevention just because, but of course there are symptoms. There is one scenario that I just spent a couple hours on the phone doing a prior auth for when we see a lot of left main calcification. That makes us nervous, and that's often a reason we may send somebody for a CCTA just to exclude significant obstructive left main disease in particular. The photon counting CT, I mean, we're getting one and everybody's very excited about it. My idea on that is that that's probably helpful in terms of complicated CCTA things, like if we're trying to determine degree of, already people have stents, there's cabbages, but I think again, for the primary prevention indications that we've been talking about, probably just a norm for most patients. Again, there's obviously going to be cases where the quality is not as great. A regular CCTA is good enough.
Thank you very much. Yeah, here at Montefiore, we do the same. We don't stop for any CAC. And I would say, I think there's value because maybe you may not be able to identify stenosis in a distal vessel or in a mid vessel, but if you can rule out left main or proximal LAD, that has a lot of value. I think it's just a question that I think is very important. In asymptomatic patients, do you guys think it's important to identify stenosis with CCTA?
I can jump into the quick opinion. I think the answer is no. I think largely. I think the plaque burden model wins here. A great paper from Martin Mortensen from Denmark that kind of examined this in the Western Denmark Heart Registry, the primary prevention population, showing basically that the calcium score predicts risk. Similarly, I mean, you have to look at the study to understand the way the analysis was done, but compared to kind of a consideration only of non-obstructive or obstructive disease. And we have to be careful. Right? We have to be extremely careful in primary prevention. It gives me a lot of pause when I hear a lot of CTA use in primary prevention in the wrong hands, because people are going to get referred for stress tests and CAS despite being asymptomatic. It's just the way it works. So yes, I'm a big fan of calcium scoring in this scenario. And kind of, even if you do read a CTA, those of us that read CTA, clearly Leandro and Maris and I and a couple, I know my fellows are on the line, we have a different perspective when we're reading in this scenario than when we're reading in a chest pain patient. We're going to be trying to communicate plaque burden. So that's really important. So, but we all are aware of people get inappropriately use of downstream testing based on an equivocal lesion that we need to be cautious of. So anyway, that's my take on kind of where stenosis fits into these patients.
I would add a few things. So the first thing is the asymptomatic status. I think this requires really good discussion with the patient. I think there is a difference between asymptomatic patients that's obese, 65, and if you really talk to the patient, you realize that they walk to the kitchen and to their garage in the car, and that's the level of their activity versus somebody who is very active and does the stuff. So it may require sometimes actually evaluate the symptomatic status by putting the patient, let's say, on the treadmill, or really encouraging figuring out whether the patient is symptomatic. There is a caveat of that. The other thing is that we have as a group, as people that do the prevention, we have to be really careful from the outside world. There is this perception that we do the test, let's say we do calcium score stress testing or do CTA, and then ensuing of that is a sort of interventional treatment that, as we know, is probably not preventing future cardiovascular events. And we get, in the way, in quotes, bad rap for doing that. So, and that requires time with the patient. I think that's very important, that you get the patient in the clinic after the test and you spend the time with the patient, and instead of reflexively ordering further tests, you actually talk to the patients, you talk to them about the data that we mentioned. You don't really improve long-term outcomes by revascularizing. Your risk is mostly modified by medical therapies and changing your lifestyle. And that's difficult. You know, that takes a lot of time, especially when the patient is anxious, when you have to spend probably a few visits, 30 minutes or an hour with the patient. And that's difficult in sort of busy practice. But that's, in my opinion, is the real value for the patient. You take the results of whether it's calcium score, CTA, and really spend time with the patient to explain what matters, which I think are the preventive therapies and changing his lifestyle.
I'll just make a quick PSA for, especially if there's fellows on the line. It's more than the stenosis. So I can't tell you how many times somebody gets a CCTA in the emergency room for intermediate risk chest pain and they say all clear, and then the patient has plaque and we haven't started therapy to reduce their risk. So look at the plaque, and thank you, Dr. Marin, for reviewing kind of the staging process, but some plaque, even some plaque, is predictive of risk.
I think these are all incredibly important points we've brought up. We want to make sure that we're appropriately treating patients based on what we know today is going to provide benefit, and calcium scoring should not get in the way of fear of downstream testing if done appropriately. Thank you all to our panel for joining us today, and we're going to take a quick break, and then we will meet back in about, I think it's 10 minutes. We have a 10-minute break, and then everybody will meet us back here at about 11:35 to 11:40.
Thank you, everyone.
Thank you.
Hi, everyone. Welcome back. Hopefully you had a nice break and you enjoyed the first session. I know we enjoyed it a lot. And now we're moving to the second session of the day. This will be about beyond CAC and stenosis. So we will have the first talk by Damini Day. Then we'll have Dr. Matt Budov, then Borja Ibanez from Spain, and Charis Antoniades. So it's a very exciting session that I think we will be learning a lot. So it's a real pleasure to introduce Dr. Damini Day today. She will be speaking about quantitative plaque analysis to guide ASCVD prevention. Are we there yet? Dr. Damini Day is a professor of medicine and biomedical sciences at Cedars-Sinai in Los Angeles, a co-associate director for the Biomedical Imaging Research Institute, and also a great friend and researcher. Thank you so much for being here.
Thank you. Thank you, Leandro. Thank you for the invitation. And I'm really honored to be here to talk about quantitative plaque analysis to guide ASCVD prevention. Here are my disclosures. So we'll start with high-risk plaque features, which we can assess visually from standard CTA. And this is a part of the CADRAD's categorization. So there are 4 that we normally report, and that is low attenuation non-calcified plaque. And so this is an area in the non-calcified plaque close to the lumen, which is less than 30 Hounsfield units. A spotty calcification, which is small calcifications in a specific, maybe in a specific configuration in the non-calcified plaque, and a napkin ring side, which is a rim of fibrotic tissue around the low attenuation plaque, and then positive outward remodeling of the vessel. And so those have all been linked to major adverse cardiovascular events. So here is data from the PROMISE trial, which was published by Dr. Maros Ferencik. It's the CTA arm of the PROMISE trial with over 4,400 patients, 52% women, and a median follow-up of 24 months with 131 MACE events. And here you can see that the adverse plaque features visually assessed, as well as severe stenosis, could stratify risk of MACE in this CTA arm of the PROMISE trial. However, among 131 patients with MACE, 67% had no visually assessed high-risk plaque features, and this could perhaps be attributed to diffuse atherosclerosis, and also the particular anatomical coronary artery disease. So we know that we can actually quantitatively measure plaque from coronary CT angiography. So here on the left side, you have an artist's rendering of the vulnerable plaque with lipid-rich plaque and a thin cap fibroarthroma, which has ruptured and is causing a thrombosis, which is reducing flow to the myocardium. But in the CTA images, this can look like on the right, with the lumen in blue, non-calcified plaque in red, and low attenuation non-calcified plaque in orange. So in the Scott-Hart trial in 2020, Dr. Williams published in Circulation this analysis of the CT arm also of the Scott-Hart trial, where we have the low attenuation plaque that you see here in orange, and the patients, particularly with larger low attenuation non-calcified plaque burden, were nearly 5 times more likely to have subsequent heart attack, and this outperformed cardiovascular risk factors, luminal stenosis severity, CT calcium score, as well as the total plaque burden. So low attenuation plaque volume from CTA has also been validated with NIRS-IVAS, and here you see a study from Dr. Matsumoto and Dr. Shinke, which has been published in Radiology Cardiothoracic Imaging. But we know that AI can really accelerate the measurement of quantitative plaque, and make it actually applicable for clinical practice. The scope of AI, as you know, is in everywhere, and it's part of the patient's trajectory through the hospital or the imaging center. So for image acquisition, for the selection of the correct protocols, image reconstruction, image quality and improvement of the image quality, segmentation and quantification, and then finally in classification and reporting of disease, and prognostication and management, whether it be through revascularization or medical therapy. So this is work from our group showing the benefit of AI-enabled plaque analysis. So this is an on-site AI model which accelerated the computation time from about 27 minutes by experts to of the order of seconds. So the AI model performed with excellent concordance with expert readers, as well as with invasive intravascular ultrasound. So you can see the non-calcified plaque and calcified plaque here on the left-hand side. And in external application in the Scott-Hart trial, could show that total plaque volume, which is high, about greater than 283.5 millimeter cubed, was predicted risk of heart attack over 5 years. And this persisted when adjusted for quantitative stenosis as well as the clinical risk score. Total plaque volume has also been shown in the ischemia trial. So this is over 3,700 patients in ischemia who also had coronary CT angiography, and plaque assessment of plaque and stenosis was done in this highly diseased cohort with Clearly analysis. And you've already heard about the staging system of Clearly. So these are the three different stage 1, stage 2, and stage 3. And this could significantly stratify risk of cardiovascular death and myocardial infarction in this severely highly diseased cohort. But however, the predictive value was modest, with the AUC increasing from 0.61 to 0.65. So this is a very hot topic, and as you know, there's several options available in clinical practice already for quantitative plaque analysis, and so it's very important to actually understand what are the challenges. And for this, there is a really comprehensive quantitative CTA guidelines from the Society of Cardiovascular CT, which is in the Journal of Cardiovascular CT, and it's listed here. And important to know that the details matter. Software ideally should consider the effect of acquisition. So X-ray tube voltage, tube current, luminal contrast, noise, and reconstruction parameters on the plaque output and the lumen wall segmentation. And it definitely needs to be tested with your data sets. So also, there is different amounts of plaque burden in men and women, and this is well known. So we performed a study where, this is an international multi-center study, where we constructed nomograms or percentiles similar to the coronary calcium scoring percentiles that everybody is familiar with. And so you can see here that for women, the 90th percentile has much lower total plaque volume than men of the same age. So that's important to consider. But do the percentiles can also actually be used for cardiovascular risk stratification? So we tested that. So the highest risk of MI was myocardial infarction was in the greater than 75th percentile that you see here, followed by 50th to 75th percentile, with the lower risk less than 50th percentile. So this is one patient from our hospital. This is a 64-year-old woman on statin therapy who had a mild amount of plaque, non-obstructive in the LAD vessel only. And so she was on statin therapy, moderate statin therapy, with the LDL reduction of only 18%. But here, even here, you see that the total plaque over 2-year follow-up is reduced. But importantly, the high-risk plaques, non-calcified and low attenuation plaques, plaque volumes are reduced, and the calcified plaque is increased, and that's what we typically see. And I'll go to the next slide. So I'd like to talk about this paper, which is a prospective study, and it's actually just in press last week. This is the EVOLVE study, which was done at Cedars-Sinai Medical Center, and it's with a prospective PCSK9 therapy, evolocumab. So patients with severe arteriosclerosis were initiated with the PCSK9 therapy and imaged in a year and a half with CTA and plaque analyzed, as well as sodium fluoride PET, which can identify the vulnerable feature by uptake. And sodium fluoride uptake signifies activity in the microcalcification of the plaque. So in this study, what we saw is, there's one example here. So we can see in a year and a half, there was a significant reduction of non-calcified plaque and low attenuation non-calcified plaque, and an increase in calcified plaque. So this is what we see here as well. The sodium fluoride coronary microcalcification activity was significantly reduced. And this is kind of a measure of all the activity of coronary microcalcification by sodium fluoride in the entire coronary tree. So here. So it's from this study. So you see here reduction of non-calcified plaque and low density non-calcified plaque, an increase in calcified plaque, and a reduction of coronary microcalcification activity, as well as the target to background ratio. So those are individual parameters which can be measured from the coronary tree, but what can we actually do for the patient? So this is a study which shows how AI can be also used to integrate plaque and stenosis to predict certain outcomes, and in this case, FFR-defined ischemia. This is impaired FFR in the Pacific trial, and you can see that the quantitative stenosis as well as plaque features can contribute to risk of impaired FFR in the vessel. The lumen parameters are in blue and the plaque parameters are in red. Quantitative stenosis is the highest parameter here in the Pacific trial from the lumen, and low attenuation plaque, the highest plaque parameter. And here the machine learning prediction is in red, and it was equivalent to FFRCT, which was also performed in this population. And both were significantly higher than stenosis. So for the patient, we can also look at explainable features. So for example, here's on the top is one patient with impaired FFR, and you can see what are the plaque and stenosis biomarkers which contributed to the risk of ischemia. In this case, maximum diameter stenosis and low attenuation plaque volume, area stenosis, and another lumen parameter called contrast density difference. And in the lower part, you see a patient whose risk of impaired FFR was low. And here there was high stenosis, but it's mostly calcified vessel. So the probability of ischemia was low in this patient. So finally, to summarize, we know that AI-enabled quantitative CT improves diagnosis and prediction of events and may individualize medical treatment. You've heard about the Transform trial, and several other studies are also ongoing to try to determine how coronary plaque can actually individualize patient treatment by adjusting the medical therapy. So for precision medicine, we do need to integrate patient risk. And for those who are skeptic of AI, think of AI as a tool, not a creature. And this tool does need to be checked and supervised, particularly with your data set. Thank you very much for your attention, and thank you for the invitation.
Thank you, Dr. Day. That was a really great summary. And I am so honored to introduce Dr. Matt Budoff. He's a world-renowned expert in cardiovascular imaging and preventive cardiology. Matt's been a pioneer in using CT technology to both detect and treat heart disease. He's also a professor of medicine at the UCLA School of Medicine and the Lundquist Institute. And he's going to be talking to us today about imaging plaque progression and regression as treatment targets. Matt, thank you for joining us.
Thank you so much for having me, Allison. It's really an honor to present with so many great other presenters, and I promise my Siri is turned off, so we will get rolling here. Sorry, there we go. So I think we've seen this slide before. Dr. Marin showed this earlier, and my point of showing this slide when we're talking about tracking atherosclerosis is just a very simple concept. I think we all recognize it, is that as plaque goes up, risk goes up. And you've seen a number of examples of that. And obviously, we've done a lot with with the score, calcium scores above 300 being secondary risk prevention, as you heard from Dr. Rodriguez, and how you can individualize therapy with the lack of plaque from Dr. Blaha. But I think the concept of those are all great population-based examples of how to use this test, right? Generally, a person with a high calcium score is at higher risk. Generally, a person with more athero is at a higher risk. But I think the ultimate treatment and the ultimate proof of somebody who's not at high risk is somebody who's not progressing their atherosclerosis or even perhaps regressing their atherosclerosis, which we've seen with a number of therapies. So the concept I want to share with you is that using some of these new AI tools, and we've heard quite a bit about them already, but I think it's really important to recognize that as we start to apply these tools, we can really individualize treatment. So we have this capability. This was actually from a study I did about 10 years ago using an anti-inflammatory therapy, not colchicine, but a 5-LO inhibitor, that we looked at plaque volumes. And we used to do it semi-automated. So it was very time-consuming to make individual measurements. We didn't measure every slice like IVUS, but we had to aid the computer in defining the center line and getting plaque volumes. But we could see both the plaque and the lumen over time. When we think about how well does this track, we have great data from intravascular ultrasound. For example, a 1% increase in plaque atheroma volume is associated with a 25% increase in atherosclerosis in cardiovascular events. So how well does that correlate with IVUS? Well, you can see the correlations. This was a nice paper from the Society of Cardiovascular CT, really excellent. And this is old 64 slice technology, and yet the correlation was nearly perfect. So when the amount of plaque volume we identify on CT is very concordant with other invasive techniques. So that's very important information. The other important information is that these tests are quite reproducible. This is work that I did when I looked at the effect of testosterone over time. We also did an inter-reader and inter-scan variability study, and you can see excellent correlation with the amount of plaque measured on the first time and the amount of plaque measured subsequently. So it's a reproducible test, it's very sensitive, and it correlates with intravascular ultrasound. So how can we use this in an individual? Well, this is my study on testosterone I published now 8 years ago, quite a while ago. But you can see that if you gave a group of men testosterone on average in 1 year, their plaque volumes went up. Red is the testosterone group, blue is placebo. So in this double-blind placebo-controlled trial, administering testosterone was actually harmful. And we know that from clinical trials as well, at least in the first year of giving testosterone to men. There is an increased cardiovascular risk in every study ever done, including the Traverse trial. There's at least an early increase in events, and we see an early increase in atherosclerosis. So I use this in my older men. If they really insist on going on testosterone repletement, I watch their individual plaque, and I look at their plaque at baseline, and I follow them up. You can do a CT angio as early as 1 year. You don't need to repeat it annually, but you can do it as early as 1 year. Most of our plaque progression trials are 1-year trials, and you can see the effect of the intervention on athero in your individual patient. So now we're personalizing medicine to the maximum degree. What is going on in the coronaries of my patient? And that's the power of CT angiography in tracking atherosclerosis progression. There's been a number of interventions that have been proven. You heard from earlier, we saw the DISCO trial from Dr. Ferencik. We saw the EVOLVE trial with evolocumab with Dr. Day. There's been a number of different interventions with PCSK9s and diet, testosterone, statins, of course. I wanted to show you a couple that I think are nice proof of concept and therapies that I use in my preventive practice when appropriate. So this is the Evaporate trial. This is icosapent ethyl, 4 grams or placebo, prospective randomized double-blind placebo-controlled trial, 18-month follow-up with CT. And you can see very clearly that the plaque regresses in blue under the influence of statin plus icosapent ethyl and statin monotherapy. And remember that aggressive statin therapy, when the LDL is below about 55 milligrams per deciliter, we start to see regression. But here we had, an average LDL of 92 on the treatment arm. We didn't insist in this primary prevention trial that they had to have LDLs below 70 or 55. So there was slight progression of atherosclerosis in the statin-only arm, or the placebo plus statin arm in red, and there was regression and significant differences when you looked across the icosapent ethyl plus statin therapy. So for patients who have atherosclerosis, diabetes, with triglycerides above 135, icosapent ethyl as a group reduced plaque, and I do apply this to therapies in my patients. What about colchicine? I think there's a lot of controversy around colchicine, and this is a study that was done using serial CT angiography after 1 year, looking at post-acute coronary syndrome patients randomized to low-dose colchicine or placebo. And you can see the low-dose colchicine had a reduction in low attenuation plaque volume, or that vulnerable plaque that we like to discuss. So a nice proof of concept, not a randomized trial. So I completed this study and just presented it Monday, just a few days ago, at the American College of Cardiology as featured clinical research. We looked at colchicine versus placebo in a prospective randomized double-blind trial, looking at cardiac CT after 1 year. And you can see dark blue colchicine, slower progression than placebo in this arm on total plaque volume and percent atheroma volume. Again, a 1% atheroma volume correlates roughly with a 25% event reduction. So this is very concordant with the COLCAT and LADOCO-2 trials, and not the CLEAR Synergy trial, which was acutely post-MI, which I think posed an issue with healing after an infarction and the potential harm of using an anti-inflammatory in the post-MI setting, but a different topic than whether colchicine works or not, I think. I think they answered a different question than they set out to answer. Regardless, you can see trends towards regression with colchicine for total plaque, for non-calcified plaque, for fibrofatty plaque, and for fibrous plaque, and a significant reduction in plaque progression with calcified plaque as well. So we have a lot of trials. I don't have all of them on here, but there's a lot of trials. And the nice thing to recognize is that what happens with CT angiography happens with cardiovascular outcome trials perfectly. We have regression with CT angiography with aggressive statin use on serial CT. We have positive outcome trials, of course, with statins. We have neutral trials with CT angiography and neutral trials with cardiovascular outcome trials with estrogen. We have harm and progression with testosterone, and you can see some of the other interventions that have been tested over the years. So how do we use this in our clinical practice? And I think some of these slides were actually shown. This is actually Dr. Day just presented this, but again, we can individualize therapy. We can personalize therapy. This is obviously Dr. Berman and Dr. Day's great work in the EVOLVE trial, looking at patients, a small study, not randomized, but a nice study to demonstrate that you can see a decrease in non-calcified plaque volume under the influence of a PCSK9 therapy. So we can, again, use this in a serial way. So how do I apply this in my practice? And I know Dr. Marin talked about this, and I know he does the same. We get a baseline scan, and we can get plaque quantification. So we can look at fibrofatty plaque, we can look at low attenuation plaque. With the new software, there's multiple now companies out there doing this, and there'll be more in the near future. But regardless of which software you use, you get a volume of low attenuation plaque, you get a volume of non-calcified plaque, and you can then follow it. So this was a patient who had some plaque. You can see the fibrofatty plaque in yellow and the low attenuation plaque in blue. You can see we put them on a high-intensity statin. We followed them for a year, and they had more plaque. So the plaque quantification software said it went up. Visually, it went up. So we said, okay, for this patient, achieving an LDL of 60, that was not good enough to slow or stop atherosclerosis. So we added a PCSK9 to further slow atherosclerosis, and you can now see 3 years later, stabilization, less fibrofatty plaque, stabilization of the low attenuation plaque, and overall plaque volume went down. So we can individualize therapy, not based on LDL, which doesn't work. We know that in the Fourier trial, 27,000 patients, when you achieved an LDL of 26 milligrams per deciliter, it only reduced events by 15%, which means 85% of events that were going to occur occurred. So LDL by itself is not going to tell you who's at goal and who is progressing their athero. You have to look at the coronary vasculature, I think, to be able to really individualize or personalize therapy. And now with all of the therapies that I just described, we can add colchicine, we can add icosapent ethyl, we can add PCSK9s, we can add GLP-1s or SGLT2s. The list goes on. Bempedoic acid, ezetimibe. We have so many therapies that we could potentially add to a given patient that we can really individualize and personalize treatments. So a couple warnings before I get to my conclusions as I reflect back on what was said earlier as well. One, we can't track atherosclerosis with coronary calcium by itself. It's a great tool to both de-risk and to risk enhance patients for primary prevention, but an increase in coronary calcium by itself is not going to drive new therapies or individualized therapies. Two, if you're going to track atherosclerosis, it's really important. If you're going to track atherosclerosis, you have to use a similar scanner, the same kV, the same kilovolts, or the same scanner settings, because changing the scanner settings will change the plaque volumes. And you have to use the same software. So there are significant differences between plaque assessed on company A versus company B. And if you switch software and measure it on company A and then have them measured on company B, you will get different numbers. These are not exactly IVUS correlates to the degree that I showed you. What I showed you was manual measures, and we have great correlation with IVUS. These new AI software have a bit of differences when we compare them. And most importantly, if you switch equipment and you go to photon counting, what you see is that the softwares, all of them, detect 28% less plaque. So some of what the software, these automated software is detecting, and the reason why it's 83% of patients have plaque is because some of that is not plaque. Some of that is noise in the artery. And we know that because when we used photon counting scanners and improved plaque detection or image quality, plaque detection went down by 28%. So I think we're slightly overestimating plaque. I think we're a little too sensitive, and I think we will reset. Regardless, changes in atherosclerosis are highly correlated with outcomes. We know that CT angiography can be used as a non-invasive imaging modality with low cost, low risk. The doses are now 2 or 3 millisieverts in a good scanner. It's not a lot. It's about the background radiation patients will get. It's 3 times lower than a cardiac cath. It's 5 times lower than a nuclear scan. So we can assess plaque progression ethically and safely using serial CT to inform clinicians and patients that the current therapies are working or that they're not sufficient. And as I mentioned, we have a host of different therapies that we could potentially add. So I want to leave you with this thought. This goes back now many hundreds of years to to Machiavelli. At the beginning of disease, it's easy to cure, but difficult to diagnose. But as time passes, not having been recognized or treated at the outset, it becomes easy to diagnose but difficult to cure. And I think with both coronary calcium and CT angiography, we can find the disease really early, get them on appropriate therapies, and prevent disease from forming. With that, I'll stop and I'll look forward to the Q&A later in the morning. Thank you for joining.
Thank you so much, Dr. Bullock. That was a fantastic lecture and very important when you remark all the finesse, all the expertise that is needed and all the small details to use CCTA for that particular patient group. So now, moving on to more early detection, we talked a lot about CT with CAC and CCTA. We wanted to bring you as well the use of ultrasound. And so for this, we'll have Dr. Borja Ibanez, who will be talking about quantification of atherosclerosis in the femoral and carotid arteries. Is it better than CAC? It's a real honor to have Dr. Ibanez, who works in Spain. He combines research activities as Director of Clinical Research of the National Center for Cardiovascular Research in Spain, with clinical activities as interventional cardiologist at Hospital Fundación Jiménez Díaz. Dr. Ibanez has pioneered work in the use of ultrasound to visualize subclinical atherosclerosis in the PESA trial, in very well-known work with Dr. Valentin Fuster. So a real honor to have him here today. Thank you so much.
Hello, it's a pleasure being here. So I would like to thank Alison and Leandro for the invitation. So it's a great pleasure to present some of our data related to the use of quantification of atherosclerosis in the femoral and carotids, and whether this is better than coronary calcium scoring in terms of prevention for atherosclerotic cardiovascular disease. So I don't have any conflict of interest. So I think we will agree that there have been a great advance in the treatment for cardiovascular disease in the recent decades, but despite this, there is still a growing incidence of cardiovascular disease, especially that related to atherosclerosis. So therefore, it's clear that there is a need to change primary prevention strategies in order to be able to tackle this huge problem. So current approach to atherosclerotic cardiovascular disease is to treat it either at the clinical stages when myocardial infarction or stroke occurs, or when the burden of risk factors is high enough in order to be very close to the development of events. So as I mentioned, it's clear that there is a need to change this way of doing prevention. So I'm going to be tackling four main concepts. The first one relates to the natural history of atherosclerosis, which starts early in life. And we know from some autopsy studies, and also there are some in vivo studies, and I will be showing you some of them, that atherosclerosis starts early in life and progresses silent for many decades before symptoms occur. In fact, if you can see to the right, there is a representation of the accumulation of burden of atherosclerosis, and only when there is a significant accumulation of atherosclerosis is when the threshold for having a clinical events occur. So there is a window of opportunity of the identification of the disease, which is the underlying process for most of cardiovascular diseases many decades before symptoms appear, but this has not been explored so far in a great manner. This is a slide presenting one of our cohort studies, which is the PESA cohort study, that is mainly focused on the use of imaging for primary prevention. The principal investigator for this cohort is Valentin Fuster, and I have the privilege of serving as the co-principal investigator. And in summary, we enroll 4,200 asymptomatic, apparently healthy individuals between the age of 40 and 55 years of age, both male and female, and this was back in the year 2010. And these subjects, they have undergone a screening for silent atherosclerosis in different vascular territories, which is the carotids, the femorals by ultrasound, and the carotids by ultrasound, calcium scoring, and also we are obtaining biological samples for all sorts of omics, and we're repeating this screening every 3 years. So far in 15 years, the entire population has undergone already 4 different screening of atherosclerosis, and we are halfway the 5th visit. Also in some subjects in which we identify silent atherosclerosis, they undergo what we call advanced imaging, which includes PET, MRI, and other modalities. So one of the main results from the baseline screening for atherosclerosis that you can see in this slide, and we published this several years ago, is that if you see that this population of middle age between 40 and 55 years of age, the territory with the that is mostly affected individuals by atherosclerosis is the femoral arteries, both in males and females, then is the carotids, and finally, this is the coronary artery calcification. So which means that in this age range, which is middle age, there is a big proportion of subjects who have a coronary artery calcium scoring of 0, but still they have silent atherosclerosis. As you will see during my presentation, if you are targeting or aiming to target the disease very early, when it starts, it's critical that we use a technique in which we can identify the disease, and this would be, by definition, vascular ultrasound in carotids and femorals. As I mentioned, we have some data in vivo showing that atherosclerosis starts very early in life. This is a slide from the youngest strata in our PESA cohort study between the age of 40 and 45 years of age. And you can see that 40% of males and 20% of females, they already have the disease. So which means that the disease started before, and we speculate, according to some data, that atherosclerosis may start in some subjects in a not small proportion at the age of 40 to 20 to 25 years of age. The second concept is that this young population, which already have the disease that is being started, is completely left unprotected by current clinical guidelines. And first, I want to show you some very nice data from the cardiac study, in this case, Mike Domansky and Valentin Fuster. They did a study, and I had the privilege of collaborating with this, in which they quantify which was the exposure in the cardiac study of these subjects before the age of 40, with the subsequent presence of major cardiovascular events after the age of 40. So they were able to normalize this at the age of 40, and after that, with all the risk factors normalized at the age of 40, they observed that those subjects who had a higher exposure or cumulative exposure to LDL, and it is the same for blood pressure, before the age of 40, even if later on the blood pressure or cholesterol are normalized, they have a significantly higher chances for having an ischemic event compared to subjects who have a lower degree of atherosclerosis, of exposure to the risk factors. So again, showing that in the young individuals, exposure to risk factors has a massive impact in long-term events, even if these factors are normalized at the age of 40. And we have similar data from our PESA cohort study. In this case, we have seen which was the association between LDL cholesterol and blood pressure with silent atherosclerosis progression, which is the growth of pre-existing plaques in the two different visits, or the appearance of plaques in territories where there were no plaques. And we saw that there was a clear association between LDL and blood pressure with progression of atherosclerosis, which is what we expected. But if you see, in both cases for LDL and for blood pressure, the strongest association is in the youngest strata, which means that individuals between 40 and 43 years of age, they have a stronger association between LDL and blood pressure with silent atherosclerosis progression compared to older subjects, which means that young individuals, they are more vulnerable to the deleterious effect of these risk factors on the vascular territories. And we also know from several studies, and this is a meta-analysis published in Lancet several years ago, that if LDL is controlled at the age of 70, for example, by 40 milligrams per deciliter, there is a significant reduction in terms of 20% of relative risk reduction, which is okay. But if the same LDL reduction is achieved between the age of 40 and 50, the relative risk reduction goes up to 60 or 70%, which means that controlling risk factors much earlier in life will have a massive impact in long-term events, as we have seen in cardia, in PESA, and also in these intervention studies. And we are presenting that youngs are left unprotected from clinical guidelines because this is a slide from the SCORE2 that we're using in the European Preventive Cardiology guidelines, but this is similar data from the US, the pool cohort equation, Framingham, or even the PREVENT. And as you can see here in this slide, the youngest age by which risk stratification is recommended is the age of 40, which means that subjects below the age of 40, there is no recommendation for this risk stratification for implementing any control or risk factors. And even in the youngest strata in this guideline, which is the age of 40 to 50, which is what is presented in this slide, is extremely difficult to qualify for initiating lipid lowering or blood pressure control. There are some subjects we can have LDL of 190, blood pressure systolic of 130, and as long as they are not smokers, they don't have any recommendation for starting a control of these risk factors. And this is completely in contradiction with what we have seen before. The young individuals, they are more vulnerable to risk factors. This exposure to risk factors is associated with long-term events, so therefore this is the population that we should pay more attention to. The third concept is that the detection of subclinical atherosclerosis is a precision medicine tool. We can go beyond risk factors and we can identify the actual disease. We can identify atherosclerotic plaques. There are several studies, and this is a slide from one of our cohort. In this case, this is the bioimage. This was an older population compared to PESA because mean age in bioimage was 69 years of age, and we enrolled them in the early 2000s. And you will see that even after normalizing for risk factors, both peripheral arteries, carotid atherosclerosis to the left, and coronary artery calcium scoring to the right, they are associated independently to the long-term incidence of ischemic events. But again, showing and remember that this is an older population, as I mentioned before, and in this case, it is normal that coronary artery calcium is associated with events because coronary artery calcium calcification occurs later in life. We have performed a follow-up to this bioimage study. We published this a few months ago in JACC, and we have done a 12 years follow-up, and we have observed which was the association between baseline presence of carotid atherosclerosis on ultrasound and long-term all-cause mortality. And you can see that even after normalizing for risk factors, subjects in the highest quartile of carotid plaque burden, they have a significant increase in all-cause mortality. And also a subpopulation of close to 1,000 individuals of this bioimage study, they underwent a second vascular ultrasound exam of the carotids 8 years after the first scan, and we have observed that even after normalizing for the baseline burden of atherosclerosis, subjects who had a progression of silent atherosclerosis in the carotids, they have a significant increase in all-cause mortality compared to other subjects who had a stabilization of atherosclerosis. And this study is extremely relevant because now we have a surrogate endpoint that we can use in order to be able whether any intervention targeting silent or preclinical atherosclerosis might have a long-term impact in terms of all-cause mortality. And the final concept is that atherosclerosis, which has been thought as an irreversible phenomenon, which can be halted but never regress. In fact, this is not the case, and we are proposing that eventually if the atherosclerotic process or disease is tackled very early in its course, it can be cured or it can be completely regressed. And this is based on some data, and some of them from our PESA cohort study, that there is still a lot of hope. This is data from our PESA, as I mentioned, and this is in the x-axis, you see what is the global plaque volume, carotids plus femorals at baseline in PESA, and in the y-axis, this is the global plaque burden at 6 years follow-up. So each of these dots represents one individual with certain atherosclerosis at baseline, x-axis, and certain atherosclerosis volume at 6 years follow-up. You will see that most of the population is around the identity line, which is as expected. Those who have higher degree of atherosclerosis at baseline, they have higher degree of atherosclerosis at 6 years follow-up. You can see that to the left, there is a line of red points, which are individuals who did not have atherosclerosis at all at baseline, but they have a rapid progression of atherosclerosis, and this is what we call the rapid progressors. But what I want to focus in this slide is this other population, which is to the bottom, which are subjects who had atherosclerosis at baseline. In some cases, this was a certain degree of atherosclerosis, but at 6 years follow-up, it has been completely disappeared, what we call the cure or the remission of the disease. This was only 8% of individuals, and we know that these individuals were those who controlled their lifestyle, they lost weight, they did more exercise, because this is not a pharmacological intervention study. We speculate that if this early atherosclerosis is identified and these risk factors are even controlled by active interventions, eventually this 8% of remission of the disease could even increase to 60, 70, or even 80% of remission or cure of the disease. So my last two slides is that we are proposing a new precision medicine paradigm for sustainable primary prevention. So it's critical that we detect the atherosclerosis at its earliest stages, which is when the process starts. And for that, we think that it's important to do a screening for atherosclerosis even from the age of 20. And we propose vascular ultrasound because, as we saw before, coronary calcification appears much later in the process of atherosclerosis. We consider atherosclerosis that is a curable disease as long as it's tackled early. And for that, we're proposing a precision medicine approach, which is an imaging-guided intervention, move from risk factors intervention and risk scoring towards an actual disease-centric approach. Those subjects who have atherosclerosis, no matter how is the risk scoring according to current equations, they need to have an intervention for reducing this exposure to risk factors because they already have the disease. And this is my last slide. We have started recently a very large cohort study, a new one, which is called the REACT study, which is done in collaboration between our institution, the Spanish National Center for Cardiovascular Research in Madrid, and also Rigshospitalet in Copenhagen in Denmark. And this is funded by the philanthropic Novo Nordisk Foundation. And we're enrolling 16,000 males and females that will undergo this very comprehensive screening for atherosclerosis, vascular, carotid, femoral ultrasound, also coronary CT angiography, imaging of the retina, wearables for risk factors, for lifestyle, and so on. We are going to repeat this at 8 years follow-up. And what is relevant from this slide is at the center of the slide, you will see that we are going to do a nested randomized clinical trial in which subjects who have baseline atherosclerosis, they are going to be randomized to classical risk equation approach, so standard of care, based on a SCORE2 system, and the other half will undergo an intervention guided by imaging. Those individuals with atherosclerosis, they will undergo lipid-lowering therapy and blood pressure control regardless of their SCORE2 system. And now that we have a surrogate endpoint, which is progression of atherosclerosis, which is associated with all-cause mortality, this might have a massive impact. So finally, my last slide, addressing the question whether quantification of atherosclerosis in femoral and carotids is better than calcium scoring, we propose that yes, especially for early detection of atherosclerosis at its earlier stages, which means at a stage that only atherosclerosis can be visualized by ultrasound and not by coronary calcification. Thank you very much for your attention.
Thank you so much, Dr. Ibanez. That was a really great analysis of what we can do to both diagnose and treat atherosclerosis in the young. So now it's my privilege to introduce Dr. Charalambos Antonadis, who's a leading figure in cardiovascular medicine and known for his groundbreaking work in vascular inflammation and imaging. His research has transformed our understanding of the interplay between inflammation and atherosclerosis and paving the way for more precise risk prediction and prevention, which is much what we're excited to talk about today. He's going to be talking to us about pericoronary inflammation and fat attenuation index. Dr. Antonadis is a British Heart Foundation Chair of Cardiovascular Medicine and a Professor of Cardiovascular Medicine at the Radcliffe Department of Medicine. Welcome, Dr. Antonadis.
Hello, I'm Haris Antoniadis from the University of Oxford. It's a great pleasure to be with you today, and apologies for not being able to present live, but I'm traveling at the same time. I'm going to talk to you about pericoronary inflammation and cardiovascular risk prediction. These are my disclosures. Now, first of all, we need to understand what have we been doing wrong all these years in cardiovascular medicine. So as cardiologists, we've learned that we should focus on those patients who have chest pain, who have significant narrowings in their coronary arteries, find these arteries, put a stent in, recover the flow, restore the flow, and then relieve the patient. But it has become very clear over the last 5 or 6 years that targeting the lesions that cause obstructive coronary artery disease is not enough to improve outcomes. That's because many heart attacks happen when small plaques like the one you see here in the middle break up, when they rupture and they cause heart attacks in the absence of obstructive previous disease. Now, what triggers the plaque rupture and what triggers the development of the plaques is widely accepted to be inflammation, at least partly. Now, we have seen from a recent study that we have published in The Lancet from the orphan cohort that among patients undergoing coronary CTA as part of clinical care, 2/3 of the heart attacks happen in those individuals without obstructive coronary artery disease. Only 1/3 of the heart attacks over a 3-year period after the coronary CT angiogram happen in these people with the obstructive disease. This means that it becomes crucial to find the vulnerable patient and moving away from the vulnerable plaque, which has been the dogma for in prevention for many, many years. As I have said, inflammation is now a therapeutic target for cardiovascular prevention. We have all seen the big randomized clinical trials telling us that if you treat patients with colchicine or other anti-inflammatory agents, you reduce cardiovascular risk. And that's why the ASC guidelines introduced colchicine in prevention back in 2021. And then that was followed by the FDA providing clearance for colchicine with a cardiovascular risk reduction label in 2023. The big question now is how do we find those people with the inflamed coronary arteries? If we rely on circulating biomarkers, then we can tell that somebody has systemic inflammation, but there is nothing to tell us that these patients have coronary inflammation, which is exactly what matters. In my group now in Oxford over the last decade, we have been working hard to understand how the vascular wall, the inflamed vascular wall, communicates with its surrounding tissues. When you have an inflamed artery, like the one you see here, you have the secretion of inflammatory molecules in the perivascular space. These molecules are IL-6, TNF-alpha, interferon gamma. These molecules activate lipolysis in the perivascular space and reduce the size of the adipocytes, which become small and fat-free, changing the composition of perivascular space in favor of the aqueous phase. If you treat now inflammation and you reduce inflammation in the vascular wall, you restore these changes in the perivascular space. Now, from the basic science, we know that if we have a biopsy of the perivascular fat, of the perivascular adipose tissue, we can tell how inflamed is the artery that is surrounded by this perivascular fat. However, in practice, this will never work as a diagnostic tool because we can never, of course, open the chest of patients, get biopsies, and test how inflamed the perivascular space is. This is why we spend a lot of time and effort to develop a method that uses routine coronary CT angiograms, these black and white images performed as part of clinical care, and brings to the surface the information about perivascular fat. This is called fat attenuation indexing. And by doing that, and by quantifying the three-dimensional changes of the attenuation readings of the coronary CT angiography images from the perivascular space, we can tell whether an artery is inflamed, like the one you see on the right, or non-inflamed, like the one you see on the left. When we developed this approach, we then tested it in the CRISP-CT study in 4,000 patients who had coronary CT angiograms as part of clinical care followed up for a decade, showing that if you have inflamed coronary arteries and the inflammation is measured by using the perivascular fat attenuation index, you have 5.6 to 9 times higher risk for a fatal cardiac event. Now, from the moment you develop this technique, this method, it took a lot of time, more than 5 years, to turn it into a clinical device. And what does a method like this need in order to become a medical device, in order to become clinically applicable? First of all, it had to be validated. It had to be turned into a robust tool that was done by using validation against biopsies, post-mortem studies, tissue biopsies, intravascular imaging, Then it went through a rigorous standardization process in order to become a reproducible clinical tool that will receive the regulatory clearance of a metric of coronary inflammation, which has been achieved by the development of the Fat Attenuation Index score, which is now the regulatory cleared biomarker in Europe and in the UK and Australia for coronary inflammation from cardiac CT. There is a clinical consensus statement from the European Society of Cardiology outlining the whole process of standardization of this kind of biomarkers. Then, when the technology became standardized, we brought it back to the UK and we tested it in a multi-center setting. The Orphan study is the world's largest prospective outcome study of patients with coronary CT angiograms linked with lifelong outcomes data. It includes at the moment 175,000 patients with comprehensive lifelong outcomes data collected and coronary CT angiograms performed as part of clinical care. From the first results of the Orphan study that we published in The Lancet a few months ago, it became clear that if you belong into the high inflammation group for your coronary arteries, which is above the 75th centile of the distribution, you have 20 times higher risk for cardiac mortality and 6.7 times higher risk for MACE. Of course, particularly in the US, you are very familiar with calcium score, and you tend to say calcium score 0 is a good reassurance and essentially gives you a good warranty for several years. We don't use it particularly in the UK. We use it partially in Europe. But is this calcium score 0 enough to reassure a patient? These are the results, unpublished results. This is work in preparation of publication from the Orphan study. In 8,800 patients with calcium score 0, you can see that if you belong into this red line of inflamed coronary arteries based on the PHI score, you have 8 times higher risk to die from a cardiac event. If you belong into this orange line, which is the group between the 75th and the 90th centile of distribution of the Fat Attenuation Index score, then you have a hazard ratio of 4.5. A very similar result is observed with patients with calcium score less than 10, which is also another cutoff that is used clinically. Now, if calcium score 0 is not enough, is it enough to exclude the presence of plaque, calcified and non-calcified? The answer again is no. This is from our recent paper where we performed this sensitivity analysis in those individuals with no or minimal atheroma, the ones that you don't really see any plaque, and you classified these patients as CATRA 0 or 1. Now, if you look into these patients, you will see that there is this group above the 75th centile that belongs to the red group that develops events straight on. Then there is another group on the orange that starts developing events after year 2. So the first group is probably the patients that have heart attacks because of erosion of small plaques. And the second group is probably the patients who indeed don't have any plaque. And by capturing inflammation at baseline, you predict the development of plaque, and then you predict the rupture of the plaque. Now, is it possible to have a heart attack without a plaque? The answer is actually yes. This is from the postmortem study that we are preparing now publication, in which it became clear that if you have inflamed coronary arteries based on the perivascular fat attenuation index, in the absence of plaque, and then you get the coronary arteries of the individuals, and you perform oil dose staining, you will see that you have fatty streaks in the coronary arteries of all these individuals who had coronary inflammation without visible plaque. It's just because coronary CT angiography cannot pick up fatty streaks. It can pick up only sizable plaques. Now, another concept is the add-on effect of the number of coronary arteries that are inflamed that adds significantly to risk prediction. And then you have the patients with 1 vessel inflamed, 2 vessels, 3 vessels, and then you have the green patients who have none of the 3 vessels, the LAD, the RCA, or the circumflex, with inflammation above the 75th centile, which means that these patients, they very rarely develop events. Is it time to start talking about the power of zero inflammation in addition to the power of zero calcium, and go for a combination of the two. This is probably the case, at least in practices that use this kind of metrics in Europe and the UK. So quantitative plaque assessment is very useful to understand if there is plaque, if there is no calcified plaque. But if there is no plaque, plaque analysis is not applicable. Coronary perivascular fat attenuation index score is applicable across the board because it tells you if an artery that doesn't have a plaque is inflamed, which is the one that will develop the plaque, or if it has a plaque, if the plaque is inflamed, that will develop heart attacks. Now, we talk about plaques, about stenosis, we have the risk factors, the risk calculators. I talked to you now about inflammation. The clinical cardiologists, they are confused. How can we interpret all of this information together to make sense and treat the patients? Because the guidelines tell us to treat risk, treat the patients based on their risk. And this is why we developed the AI risk model that aims to address exactly this unmet need. This model extracts information about inflammation from routine coronary CT arterograms, information about plaque, asks for the risk factors of the patient, integrates everything into a prognostic model, and gives the absolute and relative risk of the patient for a cardiac event over the next decade. And then you simply act upon the new revised risk using the guidelines. The model, this prognostic model, was developed in the US, tested in Germany, and then it was locked as a medical device, and it was brought for validation in the UK population. And as you can see, in the true external validation cohort, there was a C index of 0.84 for cardiac mortality, and this is the calibration curve showing very good calibration. Actually, when you focus on the patients without obstructive disease, the calibration is even better, which means that we can use this model to predict risk in these individuals. If you now use these coronary CT arterograms to predict the risk in the 3 risk group categories that are triggering different types of interventions in prevention, these are the kind of events you get from the model. If then you open the labels and check the true events against the predicted events, these are the curves you get. Essentially, you barely miss any event from this population. This is from the orphan study. If you focus on the patients without obstructive disease, which are even more interesting, these are the predicted events, and these are the true observed events in the cohort. Now, how to treat inflammation? Statins reduce inflammation in all coronary arteries consistently. Optimum medical therapy after an MI, statins ACE inhibitor, have a striking effect on coronary inflammation. Biologics, this is from a randomized clinical trial published recently on ortikumab with an antioxidant LDL monoclonal antibody showing a consistent systematic reduction of coronary inflammation in all 3 coronary arteries, and other biologics like anti-TNF-alpha, etc. They also reduce coronary inflammation measured by using this approach. The calculated risk now from the prognostic model is reduced by 30 to 40% even within a year after initiation of treatment with aggressive statins. And this is consistent with the results of the randomized clinical trials showing 30 to 40% reduction of risk over a decade of patients starting statin treatment. And a very similar result was observed with ortikumab. In the NHS in the UK, this technology is being used, and it reclassifies patients, and it changes the management in 45% of the patients, while a recent health economic study has shown that it is particularly cost-effective with an ICER, an incremental cost-effectiveness ratio, at around £1,300. It's estimated that it will reduce events, myocardial infarction by 11%, cardiac death by 12%, and then ischemic stroke and heart failure by 4%. In conclusion, fat attenuation index captures coronary inflammation. The standardized metric, the fat attenuation index score, is being used clinically in Europe, UK, Australia, and high inflammation predicts future cardiovascular events, even in the absence of visible plaque. So integrating inflammation, plaque, and risk factors into a prognostic model is the way to go if we want to introduce personalized management in prevention. I would like to thank the co-investigators in the orphan study, all the funding bodies, and of course the members of my team in Oxford. Thank you.
Thank you to all of our speakers in this last session. I think everyone will agree this was really great information for individualizing risks so that we can really talk about what exists out there besides coronary artery calcium scores. So I'm going to ask everyone to continue sending questions in. We've got some really great questions. I think the first question we'll address is many hospital-based vascular imaging studies seem to be unaware or unable to provide measures of carotid intimal thickening or subclinical peripheral atherosclerosis. Are there other options for getting this information?
I don't know, Dr. Budov, if you would like to answer. I can say from my perspective, I think IMT is probably out by now. And there's a very nice editorial by Borja written on this. And the idea is to try to quantify atherosclerosis using ultrasound, ideally with 3D. But at least in New York, I know there's not many centers doing it. That's why we invited Borja. He's doing pioneer work on how to do this. And it takes a lot of training from what I've heard from him on the sonographers. But yeah, unfortunately not reported enough. What do you think, Dr. Budov?
Yeah, no, I think unfortunately we just don't have the equipment that was used in the PISA study yet widely available. And because reproducibility with IMT was so poor, the American Heart Association and American College of Cardiology Society made it a class 3, maybe harmful recommendation because you measure it one day, it's thick. You measure it the next day in the same patient, it's thin. You misclassify patients because of inter-reader variability or inter-scan variability. So I think this new software with 3-dimensional work that was pioneered by Dr. Fuster and his team really, I think, will accelerate the ability to look for early disease. And I agree with everything that was said in that talk. Early detection is critical. And we can't do that with coronary calcium. It's too early to find it in teens or young adults, as Dr. Blaha mentioned earlier.
Thank you very much. Yeah, very good point. We have our next question from Gregory Kohn. He asked about the correlation between Phi and high sensitivity CRP, and I will piggyback on that, on the need for, if there's any need to test for CRP before using colchicine, or if imaging is a way to make that call.
Yeah, so I mean, I would say just real quickly, the colchicine data that was so robust did not require C-reactive protein. So while it did lower CRP, let's say in my trial that I did with the Ekstrom trial, it was independent of baseline CRP that we saw benefit. So I'm not sure we need to measure CRP clinically. At least to determine on treatment outcomes, it might help define a high-risk population. You might want to treat them more aggressively, but I don't use CRP to determine which therapies to apply. Having said all of that, Dr. Ridger will disagree with me.
And I think you're on mute.
Thank you for the question, and I agree. CRP is easily accessible, and the data suggesting the prognostic value, but it's a systemic marker. It could be reflecting inflammation not from the coronary or cardiovascular system. If you have infection, it may raise your CRP. So the specificity it's not great. Whereas for Phi, we are directly visualizing the metabolic changes around the coronary arteries. And in one of our studies, we found a weak but significant correlation between CRP and Phi. So we're looking into further how to use these two tests together. Of course, CRP is very easily accessible, and in lots of clinic it can be easily measured, but how to interpret it and do further downstream investigation, I think that's the key question.
Thank you very much. All very good points. I think as we're waiting for more questions, I will ask one to all of you. And you commented on the use of CCTA as a surrogate marker of clinical trials. The question is, are we there yet with low attenuation plaque or Phi as a viable surrogate, or what else do we need for that? Damini, if you want to start, or your point of view.
Yes, certainly. I think we are there in terms of the measurement, but we would, for individualizing individual patient treatment, we would need the prognostic data, as Marosh and Dr. Budov also mentioned. So I think the clinical data from the trials that are ongoing would really change the way we practice. I think I don't know if everybody else agrees with that.
Yeah, I mean,
agree.
I would add that. Yeah, I would just add that I think the right now we have, I think, a lot of data with non-calcified plaque. We have a couple large trials, as you've heard, ongoing, looking at plaque changes and seeing if we can intervene on the plaque. We're probably 5 to 10 years away from that with Phi, maybe sooner if trials can get started soon. But I think we're going to need to see that changing the measurement or treating the measure improves the outcome. Obviously, there's a lot of great data going on with Phi and big studies that you heard about. We haven't seen the prospective trials yet. We've seen, a couple retrospective cohorts, which I think are of interest. But I think we're going to need to see where we end up with our prospective data before we implement this in clinical practice. At least in my practice, I wouldn't be using Phi quite yet. I think it's a great research tool.
Yes, Korea, I agree as well. Both the plaque quantification and Phi are good surrogate markers, at least in the clinical trial settings, as to see to test the responses to treatment. And in the anti-oxidized LDL trial, we saw that the Phi changes could happen as early as 12 weeks. Some of the plaque changes, we would expect that for a significant change in plaque volume would take at least 12 to 18 months for that to change. So both of these tools would be a great early marker of treatment response in all the emerging treatments and clinical trials before the events happens in the trial setting.
While we're waiting on some other questions, Matt, I'll ask you a question. You gave us a nice case example of a secondary prevention patient where you had him on a high-intensity statin, then you used icosapent ethyl and then colchicine. Do you typically do sequential addition of therapies in your clinical practice, or is there a time you would do all of these up front?
Yeah, I mean, I think it's just a practical problem. I don't think most patients want to go in and get 5 new prescriptions. Some do, but very few. So in my practice, I typically will put them on what I believe to be the optimal therapy based on their underlying risk, based on, again, LDL first, of course, and then maybe triglycerides or inflammation second and third, based on the evidence. And then, diabetes maybe plays a huge role as far as GLP-1s and SGLT2s. But I typically do one therapy mostly at a time, unless there's some, unless they've had an event or something, and then I might layer in a bunch of therapies. I think in the world of prevention, we can't make an asymptomatic person feel better. We can certainly make them feel worse. And even just going to the pharmacy and paying $250 a month will make them feel worse. And they won't be patients for very long. So I take it slow and steady usually.
That's great words of wisdom.
Thank you very much. Dr. Budov, at what age do you start imaging with CCTA in your practice?
Yeah, I mean, you theoretically could start quite early. I actually use it fairly early in patients who have, let's say, FH. I know we're going to hear more about that after the break, but I think if you wanted to find early disease, I think you could use it even in, theoretically in late teens and early 20s, if you can get a good scanner with low radiation, you need a good reason. I wouldn't just do it because dad had a heart attack at age 50 and you know, the 18-year-old son wants to get tested. But I think there are some patients who I'm very worried about early athero. And in that population, I am a little bit aggressive and I will implement more aggressive therapies if I do see plaque. So I would use it selectively in their 20s maybe, and then certainly as they get older, I'm much more comfortable using it in those patients with bad family history or really bad lipid profiles, for example.
Great, very good and interesting. And we'll have a talk by Ron Blankstein in the young patients, just following on that. I guess we don't have any more, but I'll say one last question. So you mentioned about the changes in plaque as plaque regression, and there's obviously less plaque regression as compared to the impact on outcomes. Is it all plaque regression leading to the decrease in outcomes, or what are your thoughts about that correlation?
So as far as like risk and plaque progression?
Yes, improvement with therapies is higher than the decrease in plaque. Is it maybe affecting other things like PI, or is it all plaque?
I think that's a great question. I think the Transform trial and the other similar parallel studies will answer that exact question. What drives the risk lower, or what prevents events, maybe is how we could look at it. Is it the treatment and we indirectly treat PHI? Because remember, a lot of the therapies that we're using, statins, icosapent ethyl, bempedoic acid, and colchicine, all lower inflammation. So we have this mixed picture, maybe PCSK9s are cleaner. They only do LDL and Lp(a), but then we're going to have all the Lp(a) stuff coming up into play as well. So I think I would say that right now, the best evidence is if we can lower the non-calcified plaque or the low attenuation plaque, as Dr. Day has shown, I think that's the win for the individual patient. I hope that reducing PHI will reduce events, but I think we have a while to know if that's going to be true and if that's going to be important.
Thank you very much. I think we're running a little bit behind, so if you want, we can move to the break right now, and then we'll take over with the last session. Thank you so much. Hi, everyone. Well, that was a wonderful second session with amazing speakers, and I'm very excited about now the third and last part of our masterclass. We will keep going for hours, but this is going to be a short one. So we'll be now talking in this session 3 about imaging for prevention in specific populations. I mean, we put this session aiming to answer some questions about these populations that are always a little bit tricky, or that the evidence is a little bit harder to analyze. We have great speakers, experts in the field. We have Ron Blankstein, Dr. Michael Liu, Dr. Brittany Weber, Chip Lavier, and Raul Santos. So for the first talk, I'm very happy and glad to introduce Dr. Ron Blankstein, who will be speaking about the use of imaging for prevention in young individuals. Dr. Blankstein doesn't need any introduction, but he's the Associate Director of Cardiovascular Imaging Program, Director of Cardiac Computed Tomography, Co-Director of the Cardiovascular Imaging Training Program, and Professor of Medicine at Harvard Medical School. He has done extensive work in MIs in young individuals and a lot of work in prevention and CT. So it's a real honor to have you here today. Thank you very much.
Thank you very much for the introduction. It's really a pleasure to be here, and I've really enjoyed the program today. Wonderful talks from all the speakers. I'll be talking a little bit about how we use imaging for prevention in young individuals. And here are my disclosures. And I'll share with you this case of a patient I saw over a decade ago that sparked my interest in this topic. This was a 28-year-old. His name was Brian, and he came in with 4 days of chest discomfort. And as is often the case in individuals who are young. They sort of kind of delayed their presentation. They don't think it's really related to the heart. And by the time he came, as you can see here on his cardiac MRI, severe LV dysfunction consistent with the fact that he had a massive myocardial infarction, as you can also see on the EKG. Motivated by this case and other individuals who presented at a very early age, we kind of asked the question, which is, why are we seeing more myocardial infarctions in young individuals? And this is a national statistic that the proportion of infarcts in young individuals has actually increased over time when the total number of MIs went down. So we've done a lot of work. I've been part of a big team. I had a fortune of leading a big team on this area. And really what we found is that the vast majority of individuals who have a myocardial infarction at a young age, if you were to see them in the clinic a month, a year, 2 years beforehand, they would be classified as low risk. So they wouldn't meet the criteria to be on statin therapy. And in fact, when we look at how often they were actually on statin therapy before their MI, it's only about 10%. So 90% of individuals are not on any therapy before their MI, which I think is a very sobering statistic. Not only are they not candidates for statin therapy, it actually turns out that most of them have underlying risk factors. These are not MIs that are happening out of the blue. Half of them are smokers, 20% have diabetes. The use of cocaine and marijuana is also higher in young individuals who have heart attacks, and about 10% had criteria for familial hypercholesterolemia. But despite having risk factors, these risk factors are rarely treated. So was that the rationale for why plaque imaging is important in young people? First is the fact that risk scores underestimate risk in young individuals. I think this has now been shown in multiple cohorts, including in ours. The second reason of why imaging might be important is it allows us to detect coronary disease at earlier stages, stages where plaque may be more modifiable. So in advanced stages where plaque is more calcified and more fibrosed, we may see smaller changes in plaque. And in earlier stages, we have shown that there's actually more modification, more changes that happen. So this allows us to start prevention earlier. The other important rationale for imaging plaque in young individuals is that it may improve adherence. And we know that many individuals, particularly young individuals, they don't want to be on lifelong therapies, and compliance with therapy is usually not very good. Here's a result from a meta-analysis led by Dr. Tom Marwick, published recently in JACC Imaging, showing that when patients visualize their imaging results, this leads to an improvement in risk reduction, in improvement in risk factors. So the important thing is to actually show patients images of their plaque. There's something about seeing the imaging that really leads to a better understanding of why it is that individuals are treated, the rationale for treatment, and this follows with adherence. And as a result, really what we see is that when patients are found to have plaque, not only are they started or continued on aspirin and lipid-lowering therapy, they're more likely to have aggressive modification of blood pressure, more likely to be advised to increase exercise, and more likely to change their diet. Let's talk about calcium score in young individuals. Certainly, we heard a lot about calcium scoring earlier today in the first session of this program. But particularly in young individuals, what we have learned, and this is data right here published, well, over a decade ago, that the presence of any plaque in young individuals signifies a higher risk of events. So when we see a young individual that has any amount of plaque over a longer period of time, that's going to be associated with higher events. This is data from Cardia, where when they looked at individuals between the ages of 32 to 46, only 10% of them had atherosclerosis. So that would mean we would have to screen 10 different individuals to find one was plaque. That's not very favorable. By the time individuals are between the ages of 42 to 56, at this point, 30% has plaque. So the question is, can we be more selective in which patients we refer for calcium testing? Cardia was an unselected population-based study. But in this study, what they showed is that if we use risk factors to identify a high-risk group, they were able to achieve a group where 45% of young individuals had plaque, and as a result, a number needed to scan of 2.2, so that's much more favorable in terms of screening for atherosclerosis in this young highly selected group. This is data led by Mike Blaha, who gave a wonderful talk this morning. This is from the CAC Consortium. Unlike cardia, which was a unselected population, these are individuals who were actually referred for calcium scoring. And in this population, there were 22,000 individuals between the ages of 30 to 50. About a third of them had coronary atherosclerosis, so that's a much more favorable population. But of course, they were referred for calcium scoring, perhaps because there was suspicion. So this is a selected population. And on the right side of the slide, you can see that in those between the ages of 40 to 50, the proportion of having atherosclerosis was higher, nearly 40%. If we look at those between the ages of 30 to 39, about 21.8%. So this is important to know because essentially the concept is that in very young populations, the yield of testing, i.e. how often are we going to find plaque, is going to be much lower. So what are the challenges of imaging plaque specifically in the young? Well, as I just stated, the yield of testing, which is how often do we find disease, is lower in young populations. This is if we were to do unselected screening of everyone in their 30s, which is certainly not something we advocate right now. Instead, we should focus on methods of improving the yield of atherosclerosis imaging. So how can we do this? One method is to use risk factors to identify those at higher risk. I just showed you from the Young MI registry that most individuals who actually end up having events at a young age are going to have some underlying risk factors. So certainly when there's underlying risk factors, screening for atherosclerosis is going to be more reasonable. There's also some emerging data, and some of this has not been published yet, that the use of a polygenic risk score might help us identify populations who have a higher yield of testing for atherosclerosis. And then another concept is the use of incidental detection of calcium scoring. So incidental means a chest CT that was done for a completely different reason, but now we have those images and we can identify individuals who have plaque that we would not have known about this otherwise. So for example, here's a chest CT study. This is not gated in a patient who had a chest CT for a non-cardiac reason. And of course, we can see coronary atherosclerosis in these individuals. In fact, we are now leading a multi-center trial known as the AI-Informed trial to test the hypothesis that whether providing this information to clinicians will result in changes in preventive therapies. So certainly we believe that providing this information will make a difference. What about coronary CT angiography in the young? We talked a lot about coronary CT angiography earlier today. And we all know that CT angiography is used for symptomatic patients, where in our guidelines there's a class 1 indication. And in fact, in the guidelines, we state that in younger individuals, coronary CT angiography may be preferable than other types of stress tests because of the ability to detect plaque, the type of detection that would lead to the use of more preventive therapies. What we know in asymptomatic individuals, and this is in older individuals, 50 to 64, so not necessarily old, but we don't really count them as young anymore, that we tend to see plaque in roughly 42% of individuals in the ASPC study, 49% of individuals in the Miami Heart Study, but the vast majority of these individuals already have some coronary calcifications, such that the presence of calcium score of 0 in these individuals who have plaque is 5.4% in ASPC and 16% in the Miami Heart Study. Perhaps in younger individuals, we may find a higher proportion of individuals who may have exclusively non-calcified plaque, meaning that their calcium score is 0 and they may have coronary atherosclerosis on a coronary CTA. We certainly need more data on coronary CTA in young individuals, and we talked earlier today about some of the ongoing trials in this space. Certainly, the advantage of coronary CTA in young individuals would be that we can identify those who have a burden or a higher burden of non-calcified plaque, but we have to balance that against the fact that compared to a calcium score, coronary CTA is more costly. It may lead to more downstream testing when not used appropriately, and we're still waiting for outcomes data. What else can we identify in a coronary CTA? And one of the things that I think is really interesting is other measures such as epicardial adipose tissue, which is really the amount of fat around the coronary arteries, the epicardial fat. And this is Very nice data from Dr. Slipczak, who's of course chairing our symposium today, showing that individuals who have a higher volume of epicardial adipose tissue are more likely to have coronary disease. So certainly, perhaps we're looking at a chest CT in a young individual, and we're seeing a large volume of epicardial fat. We can see this on MRI as well. That should be a clue that this is someone who's more likely to have atherosclerosis, and perhaps someone that we need to be a little bit more aggressive about. Another measure that was covered earlier today is the Fat Attenuation Index, and we already had a whole talk about this, but I think this is a fascinating concept that we can now use coronary CTA to detect individuals who have inflammation around the coronary arteries. And importantly, even when patients have non-obstructive disease, or as you've seen in a prior talk, even in those with a calcium score of 0 and no obvious disease or just minimal disease, if they have more inflammation, they are prone to have more events over a 10-year follow-up. So certainly something else that we may want to see in the future is this going to be a method to identify young individuals who are more likely to have plaque in the future or more likely to have events. This is a statement that just came this week. This is a Lancet commission on rethinking coronary artery disease, moving from ischemia to atheroma. And this report states that strategies must be developed to prevent the onset of atherosclerosis, diagnose the disease early, which is what we're trying to do as imaging young individuals, and improve the implementation of known effective strategies for those who have already developed the disease. This is very consistent with the direction that the whole field of preventive cardiology is moving towards, and that is earlier identification of risk, earlier identification of atherosclerosis, and earlier treatment. And I think there's a very good rationale of why we need to start a lot of our preventive therapies much earlier. So in conclusion, traditional risk factors may underestimate risk in young individuals. Rather than risk scores in young individuals, we should think about risk factors as a much better approach to know who's at higher risk and how to treat those individuals. The presence and amount of plaque can be used to enhance risk assessment and identify individuals who are more likely to benefit from aggressive prevention efforts. But we have to remember that when it comes to young individuals, any plaque in a young person, so just a calcium score of, for example, 2 or just a tiny bit of plaque in their coronary artery should signify higher long-term risk. And the absence of plaque is not always reassuring. So we do not use plaque imaging in young individuals to de-risk them. Mike Blaha made that comment in the discussion earlier today. In young individuals, we're really screening to find high-risk individuals. We are not de-risking them. So if you don't have plaque and you're young and you have a lot of risk factors, we're still going to be concerned. I tell my patients who have no plaque when they're young, I tell all of them, you're still not out of the woods. We still have to be very mindful to treat your risk factors. There is a need to better identify young individuals who would derive the greatest benefit from imaging. We're still not ready to do calcium score or coronary CTAs in everyone in their 20s and 30s. The yield, as I showed you, would be very unfavorable if we do this in an unselected manner. But perhaps we can be a little bit more sophisticated by looking at the risk factors, maybe looking in the future at polygenic risk scores to have better algorithms on who benefits from screening. Earlier today, we discussed that perhaps one population would be if we can achieve a number needed to scan of 4, meaning 25% of the population has to have atherosclerosis to make imaging worthwhile. And finally, studies are needed on whether earlier detection of plaque would lead to therapies that could stop plaque progression or even regress plaque. Thank you all, and I look forward to discussing this further in the Q&A.
Thank you, Ron. That was really great. I think it's such an exciting time to be in prevention. We have so many tools, and we really are getting towards that point where we're not just preventing events, but hopefully preventing this disease from progressing. So we'll move ahead while we're talking about how we're treating specific populations. It's my pleasure to introduce Michael T. Liu, who's an associate professor of radiology at Harvard Medical School and the associate chair of imaging science at Mass General. He's also co-director of the Mass General Cardiovascular Imaging Research Center and director of artificial intelligence. Dr. Liu's research focuses on utilizing cardiac CT and machine learning to enhance cardiovascular health. and he served as the co-principal investigator of the Reprieve Trials Data Coordinating Center, which was a significant study aimed at preventing cardiovascular events in individuals living with HIV. So Dr. Liu is going to talk to us about people living with HIV and how do we reduce risk in this population. Welcome, Michael.
Great. Thank you for the introduction and the opportunity to speak to you all today. So I'm talking about cardiovascular prevention and imaging in people with HIV, mainly through the lens of this Reprieve trial. And just briefly here are my disclosures from the trial. So why do we care about patients with HIV? People with HIV have about 1.5 to 2 times the risk of cardiovascular events compared to age and otherwise risk-matched populations. HIV, we know, is associated with inflammation and a higher burden of coronary plaque, particularly non-calcified coronary plaque, which we think is more biologically active than calcified plaque. Statins have pleiotropic effects both on cholesterol and inflammation. And for this particular trial, we had chosen pitavastatin due to minimal interactions with antiretroviral therapy. So just to take a step back, I'm sure you're all familiar with the 2019 ACC/AHA primary prevention guidelines, which suggest statins in patients at low to intermediate risk, but then they have, I don't know if you can see this here, I have a hard time reading it on my screen, but on the left, there's certain conditions where you may, risk enhancers where you may consider statins that are highlighted, and HIV is one of those conditions. But at the time, there were really no guidelines for how differently you should treat people with HIV. So that's why we conducted the Reprieve trial, randomized trial to prevent vascular events in HIV, a phase 3 RCT of pitavastatin to prevent MACE in asymptomatic people with HIV on ART and low to moderate ASCVD risk. Here's the schema of the trial: 7,800 participants, who enrolled in the main outcomes trial to prevent MACE. And among those, 804 enrolled in a mechanistic substudy where they had CT scans and inflammatory biomarkers at study entry and after 2 years to look at changes in plaque and changes in inflammation. Just briefly to go over the major inclusion criterion, we're taking people sort of younger to middle-aged people with HIV, receiving stable ART, and with a low to intermediate ASCVD risk at different LDL thresholds. Very, very briefly, the median age was 50 in both pitavastatin and placebo arms. HIV was well controlled in these arms, and the median ASCVD risk score was 4.5 in both arms, and the median LDL was around 109. So generally a lower, low risk population. And I'll skip over the ART use, but generally the participants were well controlled. This was interesting. In this trial, we actually ended the trial early. The DSMB convened at 75% of the anticipated events and decided to stop the trial because it was clear that the statins were preventing MACE. So here's the upshot. The primary endpoint was the first MACE, and the secondary endpoint was MACE or all-cause mortality. And for both of these, the placebo arm in blue had a higher rate of MACE than the pitavastatin arm. So pitavastatin was reducing MACE by 36% and reducing MACE or death by 33%. Generally, statins were well tolerated in these groups, and there's a low but existent rate of conversion. Usually, patients in the placebo arm starting on a statin. And as you'd expect with the statin, there was a reduction, about a 30% reduction in LDL in the pitavastatin arm. There was a reduction in the placebo arm too, which was mainly related to crossover, that is participants starting a statin after being on the trial for several years. And the effect on MACE, like here, if you look at this graph of the reduction in MACE on the y-axis and the change in LDL on the x-axis, the reduction in MACE that we did see, around 35%, was greater than what you would have expected based on the reduction of LDL. And that may be related to other effects of pitavastatin beyond LDL reduction in this inflamed group. I'll spend a little more time on this slide because this is really when we talk about prevention and when is it a good idea to give a statin to people with HIV. This is this figure here on the right is the number needed to treat based on the 10-year ASCVD risk score. So if you look, with an ASCVD risk score less than 2.5, the number needed to treat is 187 people to prevent 1 MACE over 5 years. If you look at 5 to 10% ASCVD risk, you need to treat 53 people to prevent 1 MACE over 5 years. And then only 34 people with an ASCVD risk score greater than 10. So we'll come back to this in a moment. So in summary, in 7,800 people with HIV on ART and low to moderate ASCVD risk, pitavastatin reduced MACE by 36% over median 5.6 years of follow-up. And this reduction in MACE was greater than expected based on the reduction in LDL alone. So this actually, I started this talk with the 2019 ACC/AHA multi-society guidelines, but not long after we published the REPRIEVE results, several international societies, as well as the U.S. Department of Health and Human Services, Human Health Services, ACC/AHA, and others published new guidelines essentially recommending in persons with HIV aged 40 to 75 that pitavastatin is recommended with a 10-year ASCVD risk of 5 to 20%. And for people with an ASCVD risk less than 5%, they favored initiating statin, though again, there was, the risk benefit was not as clear. And that's again based on this, those results are basically based off this number needed to treat. So, ASCVD risk score above 5%, you only need to treat 50 or 30 people to prevent 1 MACE over 5 years. But then less than 5%, you need to treat at least 130 people to prevent 1 MACE. That really helped inform those guidelines. So those are the guidelines. I want to spend the rest of the time talking a little bit more about imaging. So remember how I told you within that study, we had a sub-study where participants got a CT scan at baseline and then after 2 years. And the hypothesis was there was that pitavastatin would decrease coronary plaque, particularly non-calcified coronary plaque, in addition to reducing inflammation. So we did that at 31 US sites. And Dr. Budoff and others talked about using change in coronary plaque on CT as a measure of how well a drug is working. And, we also used a similar thing with the primary outcome being change in non-calcified coronary plaque volume, defined based on the density of the plaque. Here we used a threshold of 350. If we go to the next slide. This is just an example of a study, we had done a number of years ago before REPRIEVE. This was with the atorvastatin. Here in the top row, you have a younger woman with HIV who at baseline had a little roughness to the proximal LAD. That's that teal arrow in the upper left. And then after 12 months of placebo, that's grown to a fairly concerning looking proximal LAD plaque. And then on the bottom row, you have another person who had a small proximal LAD plaque, and then with 12 months on atorvastatin, that completely resolved. So that's what we wanted to see with REPRIEVE. You go to the next slide here, the persons in REPRIEVE, they essentially were fairly similar to the overall people in the study, though we had less women than in the main study, only 17% women. What we found was that in the pitavastatin arm, there was a 7% decrease in non-calcified plaque volume compared to placebo. And when you look at the people who had plaque, which is about half the people, there was a 12% reduction with statin compared to placebo. I think that's important because, when a person gets to age 55 or so and doesn't have any plaque, the likelihood that person will develop new plaque in the next year or two is relatively low because for whatever reason, they're protected against plaque. So really most of the movement in terms of how plaque changes is in people in a year or two is in people who have plaque at baseline. And this was all per protocol, once randomized, analyzed. We also did, that was as randomized. We also did additional analyses looking at patients who actually were on the statin, which got similar results. So moving on, here are just some examples of people in the placebo and pitavastatin arm. In the top row, you have a right coronary artery with 2 serial plaques at baseline, and those have gotten bigger at year 2 on placebo. And then another person with an LAD plaque that sort of partially calcified plaque that decreased in size on pitavastatin there on the bottom row. LDL also decreased as it did in the main study, perhaps no surprise. There was this decrease in some of the inflammatory biomarkers, particularly in LPPLA2 and oxidized LDL. There was a trend towards reduced high sensitivity CRP. The overall, the baseline level of HSCRP was around 1.8 in both arms, essentially was normal. Many of the other inflammatory biomarkers and immunomodulatory biomarkers were not increased and did not change. And then looking at how did the reduction in LDL, that actually was related to the change in plaque volume, though we didn't see that with the other biomarkers. And I know we're running out of time, so just to skip ahead to 2 new things. So about a few weeks ago at the CROI HIV conference, we presented some new data, how this sub-study only had 800 people, wasn't powered for events, but we did actually see a difference in events between the placebo and pitavastatin arms. And I think one of the really interesting things is when you think about, who benefits the most from pitavastatin, it's really the patients who have plaque that benefit the most. So in what we found here, when we stratified events here on the y-axis, the cumulative probability of events, and then we stratified it by whether they were in the pitavastatin arm on the left or the placebo arm in the right, and then the yes/no here corresponds to people with plaque or people without plaque. If you did not have plaque, there was not much of a difference in terms of events in the pitavastatin arm. However, in the placebo arm, if you had plaque, you had a higher risk of events. So essentially, I think one of the ways pitavastatin is working, at least in this sub-study in people with HIV, is that it was protecting the people with plaque from having an event. Whereas if you didn't have any plaque, it didn't, there may have been a trend towards a difference, but not much of a difference. And we also saw a similar thing with some of the inflammatory biomarkers, including high sensitivity troponin. The confidence intervals on this figure are wide because, again, this sub-study was not powered for events, but you do see some trends here, and we are planning to look at a lot of these biomarkers in the overall study of 7,800 people and hope to have a greater power there. And I'm sorry, that's the slide I was speaking about. So in conclusion, primary prevention, in a primary prevention population with HIV and low to moderate CVD risk, 24 months of pitavastatin led to a reduction in MACE by about 35% over median 5.6 years, a reduction in non-calcified coronary plaque by about 7%, and a reduction in the risk of plaque progression by 33%, as well as reductions in lipid oxidation and arterial inflammation. And these changes may contribute to the overall reduction in MACE observed in the Parent Reprieve trial. Thank you all for your attention and all the participants and sites in Reprieve.
Thank you very much, Dr. Lu. That was an amazing lecture, and it's a great pleasure now to move to the next one. Also, we keep talking about these challenging populations. Now we have Dr. Brittany Weber, who will be speaking about the use of imaging for prevention in individuals with immune-mediated inflammatory disorders. Dr. Weber is the director of the Cardiorheumatology Clinic in the Division of Preventive Cardiology and Cardiovascular Imaging at Brigham and Women's Hospital in Boston and Harvard Medical School. She's doing really pioneer work in this area. I think she's really moving the field forward. So we're very happy to have you here and learn more from you. Thank you.
Thank you very much. And thank you for the opportunity to be on this exciting symposium today, both prevention and imaging, two clearly things that I think are going to push the field forward in cardiorheumatology. So I will get started because I have a large task in 10 minutes. Here are my grant disclosures, including other disclosures. And so to begin, as a cardiologist that has been interested in immunology since I can remember, everything has changed. Many people here know the landmark study was in 2017 that demonstrated for the very first time that a patient with cardiovascular disease, that an anti-inflammatory therapy that specifically inhibited IL-1 beta called canakinumab led to a reduction in cardiovascular events. This was work led by Dr. Ritker and colleagues. Furthermore, we've had a lot of presentations today that have talked about colchicine, and many people here know also the data of both Ledoco and chronic CAD, as well as the post-MI setting with Colcott that demonstrated colchicine has profound cardiovascular risk reductions. And it's quite exciting because in 2023, the FDA approved for the very first time an anti-inflammatory therapy to reduce cardiovascular events. And if you were to actually look at the FDA label, this is the same label as the statins. So this is a really exciting time with a lot more work due to in the field. Trying to advance. There we go. Okay, it's not advancing. Clicking it. Oh, there we go. Okay, so I just give you an overview of the role of inflammation within the general cardiovascular system. And I would argue to you that immunology really is going to integrate into all disciplines of medicine. And I just showed you the really exciting ways by which cardioimmunology in the left axis, where we're getting increasing appreciation of the role of inflammation within the general cardiovascular patient. But where I sit and breathe is down here on the bottom, which is taking care of patients with immune-mediated inflammatory disorders. And in this short talk, I'm going to try to give you an overview of this and hopefully talk to you about why imaging can guide prevention. And so let's understand the scope of the problem. So I would say everybody here listening today has met somebody with an autoimmune disease. 5 to 8% of the general population are affected. We know in general that women face a 1.5 to 3-fold higher risk of cardiovascular disease, and that autoimmunity disproportionately impacts women. We also know that there's an important intersection of chronic inflammation with traditional risk factors. So if you don't remember anything else, at least remember this first point, that our risk scores do not adequately estimate risk in these patients. We need better risk prediction, and that's why our guidelines have an autoimmune disease as a risk enhancer. But also remember point 2, we know that traditional risk factors, they're both underdiagnosed and undertreated. So we have to treat what we can treat today. So understanding the scope of the problem, we've talked a lot on this conference about prevention and atherogenesis, but I would also argue that we have to think much broader about a patient with autoimmune disease, and that that it goes beyond just the vasculature, which is shown here, but it can affect the pericardium, valvular, myocardial, and electrical system, including heart failure is an important endpoint. So when we think about prevention, we have to think about the scope of what we're trying to prevent. We need better risk prediction. This is in a landmark study that was published in 2022 by Dr. Conrad and colleagues in the Lancet that looked at 22 million patients and demonstrated that if you had an autoimmune disease, you were at increased cardiovascular risk. And importantly, this looked at single organ autoimmunity as well as the connective tissue diseases. And also an important point on this paper is that the number of autoimmunity diseases enhance that risk, hence that underlying role of systemic inflammation. This was another really important study in the field, and I would encourage everyone to look at this. This was in a nice Danish registry that looked at 85,000 patients that underwent coronary CT and identified 4,000 of those patients that had coronary CT, and they looked at one of 18 different autoimmune diseases. And a few important points. If you had an autoimmune disease, the ones they checked, you were more likely to have atherosclerosis, and you were more likely to have adverse events compared to somebody without an autoimmune diseases, even after you adjusted for cardiovascular risk factors. We also know that risk begins in the young. You just heard a brilliant lecture by the guru, Dr. Ron Blankstein, who I have the opportunity to work with. And this is a study we did a couple years ago from the Mass General Brigham Young MI registry that's been led by Dr. Blankstein, where we actually asked the question, if you had a young MI and you had an autoimmune disease, psoriasis, lupus, or RA, were you more likely to have adverse events? And the answer shown here on this Kaplan-Meier curve is that you did. This was even after we adjusted for those standard cardiovascular risk factors. Shown here on the right is one of the disease models I spent a lot of time researching, which is psoriasis, a very common and important cardiovascular autoimmune disease that affects the cardiovascular system. And this is an important study that was almost 20 years ago, led by Dr. Gelfing, a dermatologist in this space, where he demonstrated that the severity and the inflammation matters. And importantly, what this JAMA article also shows you is that the risk begins in the young, shown here on the left. And now in 2025, we have the expansion of imaging tools. We've been talking a lot about all the opportunities for coronary CT, but these are all the modalities that I'll utilize in my clinic every week. And I've also spent a lot of my research time also investigating microvascular dysfunction as a correlate of risk. And I'm going to show you a slide on the next. And we can utilize both coronary CT. We've been doing work on the metrics of inflammation you heard earlier, but also we can use cardiac MRI. That may have a clear role in certain of these younger patients, lack of radiation, ability to add stress flows, and get myocardial characterization. So how can we move the needle forward? So my talk is imaging, and I believe the multimodality imaging is going to push the field forward. This was a labor of love that I had the opportunity with Dr. Mukherjee and colleagues to write a scientific statement where we try to distill it down. We took the different autoimmune diseases, we took the different modalities, and we looked at the different ways you're trying to assess risk. And the key important point is that integrating multimodality imaging can improve the screening, detection, the serial monitoring. But we don't have guidelines, so we have work to do in the field. And so on 2 slides ago, I showed you the perfusion PET. And we spent a lot of time looking at microvascular dysfunction as a correlate of risk for prevention in these patients. And so this is some work from our own research laboratory. This is work in Dr. DeCarli's lab, where we've looked at coronary microvascular dysfunction with perfusion PET. And what we've demonstrated, as well as others in the field, is that across a host of different autoimmune diseases, microvascular dysfunction is prevalent. This is shown here on the left, both a study we did with lupus and then in psoriasis in the bottom. But then you say, well, does it matter? The answer is yes. This was a study from our own research laboratory. Dr. Fayer from the Yale also published a similar study at the same time in circulation imaging. And what both of these studies demonstrated that not only is it prevalent, it's also prognostic. So an autoimmune disease patient that has a low coronary flow reserve indicated microvascular dysfunction. When you don't have cardiovascular disease, this is associated with worse outcomes. So this can be an important correlate of risk. We've seen a lot on coronary CT, so I won't spend a lot of time, but we all know there's a lot of opportunities to detect plaque. We can do coronary CT, calcium scoring, chest CTs when available. We started out this morning with a beautiful talk by Dr. Rodriguez, and we have similarly been addressing these questions within this special population. And so let's talk about cardiac CT for prevention in autoimmune disease patients. We asked a similar question by what you heard earlier, is that can we move the needle forward by using innovative solutions with artificial intelligence to detect calcium scores and take data that already exists in our medical record. And I believe this is so important. And I'm very passionate about this because these are 2 patients I saw in clinic this year, one with RA, one with lupus, both on different biologics. And both of these patients had CT chests for pulmonary indications a few years prior and were not on treatment. They were never on a statin, nor had it been discussed. So we asked a question at our own institution is, can we take this data and identify calcium by an artificial intelligence method and look at both the prevalence and the prognostic significance? And I will briefly show this next slide, shown here if this goes. There we go. There's multiple different algorithms we've utilized in the group. This is work I've been doing with Dr. Blankston in our research lab. This is Nanox AI. It's an FDA cleared algorithm. There are multiple different algorithms that can detect this from chest CTs. But this is what we have observed, and we presented this at SCCT last year, and this is work under review. But this is a central illustration that demonstrated that about 50% of our patients that had no cardiovascular disease had CAC based on RA, lupus, and psoriasis were the 3 diseases. So it was prevalent and it was prognostic, as we would see in the general population. But what we observed is we observed risks similar to secondary to prevention, even at low detection of calcium. So even low levels of coronary calcium, we have a higher risk because this population is inherently higher risk. You also heard a beautiful lecture by Dr. Antonides that explained the biology based on PCAP and the fat attenuation index. So I don't have to give you the whole spill here. So you saw this slide earlier, but we've also been working with his research group and our own data from our own research institution to say, is Phi prognostic in a patient with an immune-mediated inflammatory disease? And again, we're very excited. This is unpublished data under review right now. This is work that I've also had the opportunity to work with a brilliant postdoc who's here with us this year. But what we have observed in our own cohort of patients with RA, lupus, and psoriasis is that identifying Phi and taking that highest Phi score, so going into quartiles and looking at the highest quartile, This was prognostic even after adjusting in terms of cardiovascular outcomes, and it was also prognostic in people with non-obstructive plaque. Whether this phi can change based on treatments is an open question, as we've heard from many discussions today, but I think this is going to be an important area for the field of cardiorheumatology. And so I'm out of time. It was 10 minutes, a tough topic to talk about in 10 minutes, but there is a lot of building blocks for prevention. I've discussed some of these today, the role of imaging, disease-specific risk assessments we don't have, clarifying the roles, but I want you to also remember that we have to make patients aware and we have to build the community. And so with that, I showed you some of our unpublished data today. So I want to thank Dr. Blankstein and all of our research labs, Dr. DeCarli's lab that fuel all the science I showed you today, as it truly takes a village. Thank you very much.
Thank you, Dr. Weber. That was a really great talk talking about this high-risk group of patients that we can now offer a lot more prevention options to. So I'm going to go right ahead and introduce Dr. Carl Chip Levy, who's a professor of medicine and medical director of cardiac rehab and preventive cardiology at the Ochsner Heart and Vascular Institute in New Orleans. He's also a professor of internal medicine at the University of Queensland's Medical School in Ochsner Health. Dr. Levy has been studying exercise and its role in the prevention of disease for many years, and he's going to be talking about us for imaging for prevention in athletes. Dr. Levy, take it away.
It's a pleasure to be here today. I'm sorry I can't be in person because I'm on my way at this time to lecture tomorrow in Montreal on Omega-3 again, but I appreciate the opportunity. This is a big paper we published several years ago, a decade ago, that got a lot of publicity showing that very high excessive endurance exercise can lead to ventricular dysfunction, particularly of the septum, and release BNP and troponin in about a third of people. And again, this got a lot of publicity at the time. And for any of you who do not think that there is dangers of extreme exercise, haven't worked the medical tents in some of these big races, and of course, there's occasionally even deaths in these events. This is a slide that I got from my friend Barry Franklin in Detroit many years ago, and as an example of in one of the Detroit marathons, 3 people actually died within 30 minutes of each other in that race that day. And again, many studies are showing ventricular dysfunction and releases in BNP and troponin in these long events. Again, this is a pretty common thing. Fortunately, it reverses, but shows that there is a lot of changes that occur with extreme endurance exercise. And of course, the first death recorded by history is the one of Pheidippides centuries ago. Now, the lipid guidelines actually talk about doing calcium scans and CRPs to enhance risk, but they don't tell clinicians really what they need to do or when they need to do these tests. Typically in practice, we do a calcium scan when we're trying to get someone to convince them to take a statin or maybe to enhance statin therapy, be more vigorous with statin therapy in someone with higher risk. But it's also potential to use in athletes as well. And these are, I know you had a calcium scan talk already this morning, but these are 3 examples of patients with pretty similar atherosclerotic cardiovascular risk scores, but on the left, there's no calcium, a little bit of calcium in the middle, and a lot of calcium in the right. And again, showing that these 3 individuals are at certainly way different risks despite similar ASCVD scores. And again, calcium scores vary with age, and the median values and 75 and 90 percentiles in men are listed in this slide. Again, with the 90 percentile really being high risk. And this is another slide showing the same numbers, of course, much lower levels of calcium in women at various ages. And again, we're looking at the 90 percentile here. Many studies show that calcium scans predict events. CRP does too, but the data really looks like that coronary artery calcium is a much more potent predictor of cardiac events compared to CRP, although the two have some synergistic effects. So this is a case of a marathon runner, 55-year-old marathoner with a family history of coronary artery disease, and the person has mild hypercholesterolemia that had not been being treated, did a calcium score, and it was 800 in the worst 10 percentile for his age and gender. And so a question is, can this person be cleared to continue to race marathons as he has been doing? Well, this is a big study that came out in JAMA Cardiology a number of years ago that showed in a large cohort from the Cooper Clinic that those who had higher levels of physical activity and exercise, and even more so in the marathon runners, that they had progressively higher coronary artery calcium scans. And many studies have shown the same thing. Not every single one, but the majority of studies have shown that particularly in very high exercises like marathoners, that their calcium scans are higher. And despite this, those who have the high level of exercise, whether they have a low coronary calcium score or a high coronary calcium score, they generally had a pretty good prognosis. Now, of course, the runners and the high exercises who had a lower calcium score even had a better prognosis. So I was fortunate to write the editorial about this study and talked about the fact that it's safe for these runners to continue to exercise despite their hearts of stone. I suggested in this editorial that we could do some additional things for prevention. Another editorial that I did for about 2 papers in the Mayo Clinic Proceedings, one in a paper was on high marathoners compared to low runners, had much higher calcium scores, and one from the Mayo Clinic that showed that their executive program, those that had the highest levels of fitness, also had higher coronary artery calcium scores, but fitness seems to be more important. So back to this runner. So yes, he can be cleared to race, but it's probably very reasonable to do an exercise test on this individual and use some preventive therapies like baby aspirin, statin, and at least low doses of omega-3, not high doses, because high doses can increase the AFib risk, but low doses do not, and protect against fatal myocardial infarction. Certainly AFib is also something that occurs frequently in athletes, and particularly very high runners and marathon runners. For many different reasons, they're at increased risk of atrial fibrillation. This is a meta-analysis by Paul Thompson of over 7,000 heavy exercises, and showing that the heavy exercises have higher left atrial sizes compared to non-exercises. And this is true in both endurance and resistance exercise, more so in endurance exercise than resistance, however. And many studies also show that high exercise increases atrial fibrillation. This is one in Europace several years ago, showing that vigorous exercise increased the risk of atrial fibrillation considerably. Endurance sports are particularly high risk of atrial fibrillation that increases with the total amount of physical activity. Another paper in the European Heart Journal of 53,000 long-distance skiers also showed a very significant increase in atrial fibrillation in those who were more competitive and higher volume races than in the lower volume races. So atrial fibrillation is a definite thing. So yes, it's reasonable to clear this patient to do their marathons, but we should do a stress test because of their high risk and because of the high calcium score. Baby aspirin seems reasonable. Statin therapy to get the LDL to much lower values also seems reasonable. And using low doses of omega-3, not high doses, is probably reasonable. The stress test that I would personally choose for ischemia, arrhythmias, and left atrial size is that a stress echo, because it would give information on all of these points. And if we saw, for example, that the left atrial size was very large, this would be at least a situation where we would try to get the individual to lower their alcohol intake, because alcohol intake tends to be also very high, at times at least, in heavy athletes. And this is also a very significant cause of increasing the risk of atrial fibrillation. So in conclusion, the prognosis of athletes is generally very good. Very high exercise, though, is associated with higher coronary calcium scores in many and probably most studies that have assessed this. But fitness is probably more important than coronary calcification for predicting prognosis. And of course, the heavy athletes are generally extremely fit. Still, high coronary calcium can be used to intensify prevention strategies, because those athletes with high coronary calciums do have higher risk than the athletes with lower coronary calcium. So you can still try to lower their risk by doing things like statin therapy and baby aspirin and maybe omega-3. And I think we should consider a stress echocardiogram, looking for ischemia, looking for left atrial size, looking for exercise-induced arrhythmias, which all would be very helpful. Those very high exercises generally also have an increased risk of atrial fibrillation, and color flow Doppler may help stratify the AFib risk by looking at the left atrial size. And if the left atrial size is very high, putting the athlete at a higher risk of atrial fibrillation, we could at least recommend other measures and including potentially reducing the alcohol intake, which is a major stimulus for atrial fibrillation. Thank you very much for the offer to speak here today, and I hope you're having a very good course. Thank you very much.
Thank you, Chip, very much for the outstanding lecture. Always a pleasure to see you speak about such an important topic. Okay, so now we have the last lecture of the day with one of the best speakers, according to my preference, because I love the use of imaging in familial hypercholesterolemia, as Raul knows very well. So he will be speaking about this cohort of patients in particular that has been very challenging and controversial, that are patients with FH. So Dr. Santos is an associate professor of medicine and the director of the lipid clinic at Heart Institute, University of Sao Paulo Medical Center in Sao Paulo, Brazil. Thank you very much for being here with us today. I'm really looking forward to your lecture.
Thank you, Leandro. It's a privilege to address you all. So my task is in 10 minutes talk about imaging for prevention in FH. So this is my disclosure. And actually, we all know FH, right? It's a disease that's characterized by a very high LDL cholesterol since birth that is associated with a 3.2-fold greater risk of cardiovascular disease, especially coronary heart disease, in comparison with the general population. And it runs into the families. And unfortunately, we know that actually lowering cholesterol in FH will reduce the risk of events. So how is the current epidemiology of FH? So this is data from the biggest registry that we have nowadays, the FHSC registry, more than 61,000 people with FH. And you see here the mean age is around 46 years old, half of them are women. And you see that 1 in 5 people with FH have coronary heart disease. This is more frequent in men than women. And of course, the higher the LDL cholesterol, the greater the risk of events. And then you see here, if I say that, let's say that around 20% of people with FH at the age of 46 have coronary heart disease, it means that around 75–80% don't. So showing that despite the fact that cholesterol is high, there's heterogeneity on the manifestation of the complications of high cholesterol in people with FH. So actually, we know that statins reduce the risk of cardiovascular events. We don't have prospective randomized clinical trials in this population because it would be unethical to do it. But this is observational data from the UK. And you see here that actually in secondary prevention, we still need further LDL cholesterol lowering, no doubt about that, because with statins, we reduce the risk of mortality from 5.2-fold to almost 4-fold, still very high. But in primary prevention, actually, the twofold excess of coronary heart disease death and FH is reduced to none with the use of statins, clearly showing that statins can make a lot of difference. But in primary prevention, we know that actually a lot of people still will have a greater risk of events. And there's the discussion of adding further therapies with PCSK9 inhibitors that unfortunately are not available for everyone. So basically, we know that the risk of coronary heart disease and FH depends not only on high cholesterol, but also on the presence of the other risk factors like smoking, hypertension, high Lp weight, and actually other genes that have nothing to do with the genes that cause FH might influence the risk of disease. And you can see here in this very elegant study that actually between 17 to 78% of the risk of coronary heart disease in people with FH could be explained by a polygenic risk score, clearly showing there's a big heterogeneity on the risk of cardiovascular events, even in people who have high LDL cholesterol. And actually, the question that comes is, why do image should be used in people with FH? Because you know that people that have high cholesterol, everybody should be treated with statin and ezetimibe at least. So does imaging can make any difference for these people? And actually, imaging, in my opinion, may help modulate lipid-lowering therapy in FH, considering that there's also heterogeneity on subclinical vascular disease. And as you've been seeing all this morning, that subclinical atro can help us a lot in identifying people at higher or lower risk of events. And this is data we published some years ago, clearly showing that actually around 44% of people with FH, you see that residual LDL was still high, 158, 97% of them are taking statins, actually had a calcium score of 0. So showing that almost 50% of the population didn't have subclinical atro, despite the use of the therapy. And actually, we did further on now we have not only FH, but also severe hypercholesterolemia, people with LDLs over than 190, more than 85,000 people in this data that was just submitted for publication. You see here the baseline LDLs are extremely high to 203 milligrams per deciliter. And you see here that actually people with FH, 39% of them had a CAC score of 0, in comparison with around 51% of people with severe hypercholesterolemia. And this can be explained actually because people with FH are born in higher LDL, so their cholesterol scores are higher, so certainly they have a greater chance of having subclinical atherosclerosis. The question that comes is, okay, so you have a calcium score of 0, how many people have non-calcified plaques? Because we know that non-calcified plaques can exist in the absence of CAC. And actually, this is data that we published last year at the American Journal of Preventive Cardiology here. We see here that more than 1,000 people with FH, all with molecular diagnosis. And actually, you can see here that at the older you are, the greater the chance of having plaques, the greater the chance of having non-obstructive plaques. And actually, if you're a woman, you're more protected than men. But as you get older, you get a greater chance of having plaques, obstructive and non-obstructive plaque. And actually, around 20% of our patients with the CAC score of 0 had non-calcified plaques. Fortunately, very small, less than 1% have obstructive disease. And the question that comes is, okay, if I have a CAC score of 0 and I have subclinical atro, what are the clinical implications for that of actually a CAC score of 0 or a non-calcified plaque? So what are the clinical implications for that? And indeed, we many years ago actually came with this, let's say, proof of concept study in 206 patients with heterozygous FH, all with molecular diagnosis that were followed by around 4 years. And you can see here that those with a CAC score of 0 had no events, and actually the presence of CAC was associated with a 2.6 to a 4.4 year rate of events in these patients who were taking statins. Their LDLs were around 150. So clearly showing that actually absence of CAC was associated with a low risk of events. But this is a small study, small number of events. And actually then we had data from Spain, eightfold greater risk of eightfold greater number of patients. And you can see here that the results were more or less the same. So actually those with a CAC score of 0, only 3 patients in almost 600 had events, really showing a very low risk of events. And of course, if you calcium score, especially over than 100, you really get a great chance of having cardiovascular events. This study, however, was limited by this short-term follow-up, just 2.7 years. And now we have data from Japan, data from Ayako Tada. So more than 600 patients with FH, median age 54 years. And you can see here that treated LDLs were around 108 milligrams per deciliter and 13-year follow-up. And CAC score of 0 was associated with just 1.2% risk of events in 10 years, between 1 and 100, 17%, and greater than 100, almost 80% of those patients, despite the fact that they were being treated with statins, had cardiovascular events. So now we're working on a meta-analysis, not only with patients with FH, but also patients with severe hypercholesterolemia. And you can see here more than 35,000 patients, around 2,300 of them have FH. The treated LDLs vary between 108 to 171. And the median follow-up was 5.7 years, and we had around 9% endpoints in the whole population. And you can see here that actually the presence of subclinical atherosclerosis, the presence of coronary calcification, was associated with a tremendous greater risk of events in comparison with those who didn't have CAC. So CAC score of 0 was associated with just 2% of events in 10 years, in comparison with 25% risk of events in 10 years in those who CAC score greater than 0, clearly showing here that if you treat your patients with FH with the traditional therapies, if you don't have subclinical atherosclerosis, your risk is lower. On the other hand, if you have subclinical atherosclerosis, despite the use of statins, you really have a very high risk of events. And this, in my opinion, could help us guide the use of PCSK9 inhibitors that I said are not available in many parts of the world, especially because of the costs, to really, let's say, customize the therapy of those with familial hypercholesterolemia. And actually, this is what we have proposed 5 years ago. Karan Nasir, Reed Misad, and I, we have worked on this, and definitely people who have FH, who have coronary heart disease, should be treated with PCSK9 inhibitors. But in primary prevention, actually, we can use calcium score to really help identify people with FH and a greater risk of events. And if you, let's say, we have restrictions for the availability of the therapy, or if patients are not really willing to take more medication, I think those who have subclinical atherosclerosis should receive the PCSK9 inhibitors. Certainly, we still have a long way to go. These are my conclusions, but definitely, I really like to spend a few seconds on this here. Atherosclerosis is a heterogeneous disease, and definitely there is resilience to development of atherosclerosis, even in FH. However, the study that I showed to you, despite the fact showing that CAC was associated with a greater risk event, in the absence of CAC, most importantly, without events, these studies might have included selected patients, maybe survivor patients. And definitely, we should treat all patients with FH with at least statin and ezetimibe. And the question that comes, what will be the implications of a calcium score of 0 in patients who have non-calcified plaques? Are these patients at a greater risk of events? Should also they be treated with the PCSK9 inhibitors? And definitely, we need longer-term follow-up. I think that imaging can help us identify higher and lower risk people, even in those who have risk factors. And definitely, LDL cholesterol lowering should be done in people with FH, but I think we can use imaging in order to really, let's say, do a more specific therapy, a more customized therapy in those who might need these newer therapies that are really more expensive. Thank you very much again for inviting me.
Thank you very much. That was an outstanding lecture, as always, and a very challenging group that is FH. I know you see a lot of patients in this group, so you have also the clinical experience, which is very valuable. Please put your questions in the Q&A if anyone has questions, and we'll go through them. As we're waiting for questions, maybe we can start with a question. I'll start with a question for Ron, maybe, on the use of the polygenic risk scores and the use of combination of polygenic risk scores and CCTA. That's currently not being utilized as much in general. I think, are you using it? Do you think we're ready to use it in clinical practice?
Yeah, no, it's a great question. There is data that certainly in folks in their 50s, and this is data published by Sadia Khan in JAMA Cardiology, showing that once you account for a calcium score, polygenic risk score does not seem to add a whole lot for risk assessment. So certainly from a risk prediction, it hasn't really added a lot on atherosclerosis imaging, but that's in a population that's folks in their 50s or 60s. And I think the area where a polygenic risk score is going to be most helpful is in young individuals, perhaps before the development of atherosclerosis, certainly in people who we don't want to image yet in their 20s or perhaps 30s. As the field of imaging is moving towards imaging younger individuals and perhaps asymptomatic individuals, this big concept is how do we increase the yield of imaging to identify those with atherosclerosis? So perhaps in the future, you can start with a polygenic risk score, and if that is high, that is a population that's more likely to benefit from atherosclerosis imaging. But certainly we need more data on that. And there's a lot actually in the pipeline. There's a lot of groups, including our own, that are investigating that.
Thank you very much.
Maybe I'll ask a question that was brought up earlier, and I'll pose this one to Raul. There was a question about a 45-year-old with an LDL of 220, normal lipoprotein little a, and a 0 clearly. What would you do with that person?
Definitely, I would give an statin and ezetimibe to that person because, okay, so far so good, but we don't know about the future, right? We could discuss if the LDL was still very high despite the use of these therapies. And I guess CAC score is 0. I would not prescribe a PCSK9 inhibitor to that patient, at least for what we have so far. Okay, I know we need more data, but I think all seems to converge to what we saw with other diseases and in the general population.
Can I ask Dr. Liu a question? I really like Dr. Liu's talk, and Michael, I like your slide towards the end there, showing that really the benefit of pitavastatin was in individuals who have atherosclerosis. So in REPRIEVE, of course, it enrolled all comers. If you were to do a study like REPRIEVE or the mechanistic sub-study that you led, and at baseline you only recruit individuals who have atherosclerosis, what do you think that would do to the kind of effect size and the number needed to treat of a therapy like that?
Well, I think it would be much more efficient, just because for these trials, usually the number of events what drives the size of the trial you have to do. So many of the trials we're doing now, we often do like a pre-screening where we only randomize patients to drug or placebo if they have plaque. So that would definitely help. It is hard though because certainly I've read the stuff you've written and others where just because you don't have plaque, at year 1 doesn't mean 5 years later you couldn't develop plaque. I mean, that does happen. Plaque always starts from nothing, or at least what we can't see on CT. So it doesn't protect you forever. But yeah, to get back to your question, I mean, I think it is more efficient to do these kinds of trials if you only enroll patients who have a plaque, just because it's not that common, within a year or two that you see new plaque, like completely new plaques show up.
Thank you very much.
I was going to ask Brittany a question. So a lot of the people that we see with inflammatory disorders are women, of course. What are you doing with statin therapy in this group during the pregnancy years? Are we continuing that?
Yeah, very good question. And tough, right? In general, still doing the general guidance of stopping during those pregnancy-bearing years. Certainly, I know that it's as we're gathering more data, and I was actually just talking to Kathleen Economy at a meeting 2 weeks ago about this, who was telling me that she actually feels okay in certain studies on keeping statins on, but in general, and I've discussed this with Ron in our prevention group, I'm holding statin therapy during those pregnancy years, and then the breastfeeding, and then just making sure that they know that we're going to restart once we get past that. But I just do aggressive counseling and make sure also when I'm starting it in young women that they know about that, and then to alert me if they're planning a pregnancy or they were to become pregnant.
Thank you very much. I wanted to ask a question. I really enjoyed Dr. Borja Ibanez's lecture on the use of ultrasound. And I think at least for us, we're really behind on how we're using that and complementing it. When you do a CAC of 0 in your populations, and Ron talked a little bit about the risk of de-risking in young populations, even if they have no plaque, do you foresee the use of ultrasound in these patients to enhance kind of this power of 0? Or do you think it would be useful?
Now, may I just talk a little bit about my experience with FH? Okay, our patients are not so young. Their average age is around 40 something, right? But they have been exposed to high cholesterol since ever. And we didn't find a good correlation between what we saw in the coronaries and what we saw in the carotids. And also we did the pulse wave velocities, and they didn't go very well. Especially for FH, I think the target is really the coronaries, despite the fact that in children we use IMT to identify early disease. So I really would focus in looking at the heart for this, specifically for FH, I think. I don't know whether the other regarding hypertension or diabetes or maybe other risk factors, but for FH, I think the coronaries are really the target, you know.
Yeah, thank you very much. Very, very good thought. And that's what we've been practicing traditionally. So I think, do you see any more questions, Alison? Or?
No, I think we got everything.
Okay, well, thank you very much, everyone, for spending your Saturday morning with us. And we really appreciate your help.
Thank you, everyone.
Thank you.
Bye. So, Leandro, I think this was a really great meeting. I know I have learned a lot. I can take some of this back to clinic on Monday and start instituting in some of my patients. You know, sort of the takeaways, I think, are, you know, calcium scores are really a test that we can use today. And we have a lot of options coming up for tomorrow as far as prevention. And what a great time to be alive in the world of prevention.
I agree. I really enjoyed this meeting as well. And I think the value of CAC also was emphasized. And I think another takeaway that I have from Fatima is that the information that is there, we should use it. And even if you use AI to pull the data, also we learn from Brittany in the cases with the immune-mediated diseases that we can benefit from using the data that already exist. I think a lot of exciting data is coming with CCTA. So many trials happening, and the data that Borja showed with all that they're doing in Spain with screening all the different territories. I think it's a very fascinating field to be in. Hopefully more fellows keep getting interested in joining ASPC. And I think for next year, we'll have a lot more data because it's just so many trials ongoing.
Yes, I agree totally. And, you know, and I think the one comment you heard from all of our speakers today was the concern not to do too much to people who are asymptomatic and really focus on prevention, not necessarily interventions, I think is where we are living in 2025.
Thank you very much. Thank you, everyone, for spending time with us. Hopefully you enjoy the masterclass.
And join us in Boston in August for our annual meeting.
Thank you.